We are live now, ma'am.
Okay.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for today's webinar, Endometriosis and Infertility, organized by TNFOG Marathon CME. So it's my pleasure to introduce the conveners of today's webinar, Dr. Gayatri and ma'am. Ma'am is executive member of TRIOX.
A coordinator
I
of this.
welcome you, ma'am.
Thank you.
And T. Radhika, ma'am. Ma'am is specialist consultant OBG in ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to the coordinators.
Thank you. Thank you, Sahiti. So we welcome respected faculty and all the delegates for this session of TNFOG. We welcome the chief guest and the guest of honor. Sahiti. Lamp lighting. Gayatri.
Thank you, ma'am. Marathon CME is being conducted every month, second Friday, and we've been conducting it for over the years. That's why it's called Marathon CME, where we encourage the younger doctors to participate and present cases. To introduce the program further and to invite the chief guest, I call upon our president, Dr. Vidya Prabhakar.
Thank you, Dr. Gayatri. Can we have the CV of our chief guest, please?
Vidya Prabhakar, before that I will give the introduction of the Marathon CME 1 minute.
Okay.
I welcome you all for this TNFOG Marathon CME. I am the secretary, Dr. S. Sampath Kumari. This is the Marathon CME which is conducted in 3 sessions. The first session being for the Yuva, and they will be judged by the same judge every month. As Dr. Gayatri told, it will be conducted on second Friday. And the second session being the update of the theme which we are doing. And third being the panel discussion of the same theme, with the seniors having the moderator and the panelist. We give the Yuva Orator Award at the end. That is in the TNFOG annual conference for the best Yuva orators, which is conducted every month. This is the TNFOG Marathon CME. I welcome our chief guest, Dr. Hara Patnaik sir, and the guest of honor, Dr. Raki Singh. Now I hand over the mic to Dr. President Dr. Vidya Prabhakar to introduce the chief guest, Dr. Hara Patnaik sir. Yes, madam.
Thank you, ma'am, for that wonderful explanation you've given. I'm sure the newcomers will not be knowing about what is this Marathon CME. Thank you very much for doing that. And this is actually the brainchild of Dr. Sampath Kumari, ma'am. I think that also should be highlighted. Okay, so I think that also should be highlighted. Yeah, so I'm extremely honored and privileged to welcome Dr. Hara Patnaik, who has been the Vice President Foxy in 2009. He has also held various other posts like President of Association of Obs and Gynecological Societies of Odisha and Governing Council member of ICOG, National Corresponding Editor for Foxy Journal. He has been the chairperson of Geriatric Gynecology Committee in 2004 to 2008 time. And apart from all this, he has also been the Secretary General Society of Vaginal Surgeons of India, SOFC, and president of the Indian Menopause Society. And the icing on the cake would be that he has also been with the government. He has been the ex-special secretary for Health and Family Welfare Ministry, Odisha, and Director Health Services and Director Public Health, Odisha. So I think we have somebody who not only does OB-GYN, but also takes part in the regulations and all the principles and policies of the government. We are very thankful to have you here, sir. Welcome, Dr. Hara Patnaik, sir.
Thank you, madam. Thank you, madam,
He
for
was
those kind
Dean
words.
also, Vidya.
Yeah, that's
Thank you,
I'll
madam.
include that. Yeah, thank you.
Thank you, Madam Vidya, for those kind words.
Thank you,
I
sir. And
really-
we are hoping that we'll get all that insight from you because you've been in all these important positions.
It's all, Madam Vidya, I really congratulate you and also Dr. Sampat Kumari as well as Dr. Gayatri for this marathon CME, which you have planned for the benefit not only for the young postgraduates and practicing gynecologists, but for the seniors on different subjects, taking one theme at a time every month. This is really something unique. Even though we are having a lot of webinars and lectures and conferences, but teaching in the real sense comes from these focused CMEs. So, and Tamil Nadu is really famous not only for its classical dances, for its art and culture, but for the academic scenario. And it has shown light to different parts of the country, and gynecology is no exception. This month, you are having a CME on endometriosis and infertility. Well, endometriosis and infertility, we all know that they go together. So when there is endometriosis, there is pelvic pain, there is dysmenorrhea, there is infertility. And the real crux of the problem occurs when this woman who is suffering so much every month comes to you in her early marriage of having infertility. And managing endometriosis in infertility is really a challenge. And many people have suffered. Many drugs have come out today, and many surgical procedures are being demonstrated for the benefit of our gynecologists to learn and practice in the field, in their respective practice and in their field. So let's see. I am very lucky, and I feel myself very happy that I have been invited to this forum as a guest. I am a friend of yours, not as a guest. I thank you very much for inviting me, and let me hear from the stalwarts as well as from young postgraduates what is there in mind and what new light they are showing us today. Thank you very much.
Thank you,
Thank
sir.
you very much, sir,
Thank
for
you.
those beautiful words. Ma'am?
Yes, sir. Thank you, sir. Really, we are happy to have you here. Vidya Madam, next introduce our guest of honor, Dr. Rakhi Singh.
Yes, it's my pleasure to invite Dr. Rakhi Singh as guest of honor today. She has been so busy. She's been delivering a lecture here, there, and then on the way now. In between, she found time to come and attend our webinar as well. So welcome, Dr. Rakhi Singh, ma'am. She became very close to us when she became the chairperson of Endocrinology Committee of FOXI. She has also been vice chairperson of UP State SR. She's been a peer reviewer for Journal of Obstetrics and Gynecology of India. And she's got a lot of awards to her credit. And, she's got the Wonder Foxian Award, the Dheera Award, the ICOG Appreciation Award. And she's also written a lot of chapters in books like Foxy Focus and Jeffcott Gynecology, Fibroids Management, Desire Express, Dilemmas in IUI, Yearbook of Obstetrics, GCPR, everything, you name it, everywhere, wherever there is anything new coming up and there are publications, you will find Dr. Rakhi Singh's name. And she's been an invited faculty for so many national and international conferences. She's also got the Foxy DC Datta Award for publication and CS Dawn Award as well. So a lot of awards to her credit, and we are extremely fortunate to have her as guest of honor today. Madam, please share your wisdom with us today, a few pearls of your wisdom.
Thank you, Vidya, for that big, generous introduction of yours. And it's a very good initiative, as Dr. Hara has also told, that the PGs are involved, the young budding gynecologists are involved for the webinars, and they get really because they don't have that much amount of time to go and attend the CMEs. So this is one of the helping part of it, which they do it once they attend the webinars. And apart from this, uh, as you all know, I've been working at length with the endocrine committee, and I have worked at length with the endocrine committee, and I was there as the endocrine committee chairperson with all the varieties of work what I had done. And apart from this, Dr. Sampath Kumari is another big doyen, which you all know of. And I have kept on visiting and learning many things from her. And today's, hello, can you hear me?
Yes.
Yeah, we
Yes,
can hear,
Rakhi.
ma'am.
Yes, yes.
And Dr. Sampath Kumari madam is another big doyen, which is from her, which I have learned so many things. And all of you, Vidya, all to name all of you, one and all, we've learned a lot from all of you also, because learning is one curve that in each and every webinar you log in, any lecture which you see, even if you are interested or not interested, if you are sitting in that, subconscious mind will definitely absorb certain amount of the product what is given and everybody is teaching over there. So subconsciously we do learn. So it is always important to on it and sit down, even if you're doing some other work, because the next level of the mind does listens to it. And endometriosis is one big enigma, which is very difficult to diagnose in these adolescents. And the only key to it for the adolescents to be diagnosed would be that once it starts hampering the day-to-day activities and they start missing the school, they start having problems going to the school, going to become a social person, and they start missing on every occasion, and they are bedridden, and they don't want to be connected with everybody. There we know that it could be endometriosis. Once these children start, adolescent or the reproductive age group, once they start asking for the medication, for the pain relief just before the cycle, we should have an eye. We should have that vision that it could be endometriosis. That is how we know that it can be endometriosis. Until unless we have that susceptibility in the mind, we will not even come to know for that. So it is very important to listen to these webinars, and who could do better than Madam Asha Rao ma'am, who's speaking on endometriosis, and another big doyen who's speaking on embryology for us. All the best to all of you and a happy learning. And at the outset, just ending my thing, I would like to request all of you, I'm standing for Vice Presidency. Please do remember me. I'm standing from North India, Dr. Rakhi Singh. Thank you.
Thank you and all the best,
Dr.
Raki.
Thank you, ma'am.
Sure. Yes, all the best, Raki. So this webinar will be in the YouTube, and every month we have more than 400 to 500 likes for this webinars in the YouTube. You can see, I will put the link tomorrow. Now we will start with the scientific
I
session.
think,
Radhika
Dr.
and
Sampath, ma'am,
Gayatri.
you need to, Dr. Sampath,
Yes.
ma'am, I think you need to share these webinars regularly with all the groups also, because that will
Sure.
help you to do more.
Yes,
Sure.
I'll do that. Sure, Raki. Thank you. Thank you,
Yeah.
Hara sir and Raki. If time permits, be there for our scientific session. Yes, Radhika, you can proceed.
Yes,
Or
ma'am.
Gayatri.
So, thank you so much, Raki ma'am and Patnaik sir, Sampath ma'am and Vidya ma'am. We will proceed to the academic session, session 1. We invite Dr. Shanti ma'am, who is our chairperson for this. So she's a professor and Department of Obs and Gynae, Savitha Medical College Hospital in Chennai. And she's done her MBBS and MD from Madras Medical College, trained in ultrasound, advanced infertility, advanced laparoscopy, also provider. And her field of interest is endoscopy, high-risk pregnancies, adolescent gynecology. And she's been examiner for the UG and PG and invited faculty in conferences. Welcome, ma'am. And we have our another judge, Dr. Kartika Prabhu. She is a professor, SRM Medical College Hospital and Research Center, Katanklatu. And she's done her MBBS from MMC and MD from JIPMER. She is an undergraduate, postgraduate teacher, and her special interests are in high-risk pregnancy. She has received numerous awards, Dr. Asha Bakshi Award, Dr. A.V. Umaguchi Memorial Gold Medal, and prize for paper presentation, Yuva Foxy, and gold medal for the research day on SRM, and Dr. A.L. Mudalia Traveling Fellowship, and more than national, international, 20 international national publications. She's also faculty, national and regional conferences. Welcome, ma'am. And we hand over this session to you. Dr. Kartika, ma'am, can you please introduce Dr. Janani?
We have the first speaker who is going to talk on Tubal factor in infertility, Dr. Janani. She is a fertility consultant in Ananda Fertility Center, Salem. She is a university gold medalist in MBBS as well as in PG. She has won a lot of gold medals, and she has won the Best Research Paper Award from Foxy PG Research Talent in 2020. She's also a quiz winner. She has publication in various national and international journals. Over to you, Dr. Janani.
Good evening, everyone. Thank you, ma'am, for your introduction. Ma'am, is my slides visible?
Yeah, it's visible, Janani.
Yes, ma'am. Please make it as full screen.
So your time is 12 minutes and 3 minutes will be for discussion.
Okay. So I'm going to talk about tubal factor infertility. So we all know that fallopian tube is a tubular passage connecting the uterus and the ovary. So if there is any blockage in this passage, it can cause tubal factor infertility. The incidence of tubes.
Sorry to disturb, ma'am. We cannot see the screen in full screen.
Make it PowerPoint, no? The show.
Yeah, slideshow. 1 second.
Slideshow, it's not slideshow yet.
I'll do it again. Now, ma'am, is it visible?
No, ma'am.
No, I can only see you.
Now, ma'am?
Yes, ma'am. Now we can see in full screen.
Okay.
Thank you, ma'am.
Okay. So the fallopian tube is a muscular passage connecting the uterus and the ovaries. If there is any blockage in this tube, it can cause tubal factor infertility. The incidence of tubes being the cause for infertility is 30 to 40%. And out of which the proximal tube getting obstructed is 10 to 25%. And the most common site is the distal tubal obstruction. So what could be the causes for these obstruction? If it is a proximal tubal obstruction, a simple mucus or a debris can cause the blockage, or even the corneal spasm while doing HSG because of the pain. It can also be seen as a blockage, or a sulfangated systemic nodosa or endometriosis, or a simple fibroid sitting in the cornua, again can cause this obstruction. In distal tubal obstruction, it can be because of hydrosalpinx, the common cause, and also fimbrial phimosis. These can be because of infections, pelvic inflammatory diseases, commonly caused by chlamydia, gonorrhea, and even also because of tuberculosis. And peritubal adhesions can also cause distal obstruction, which can be because of previous surgeries or any peritoneal inflammation like endometriosis can also cause this. So how to check if the tube has obstruction or not? We have various tests to check the tubal patency. They are insufflation test, HSG, laparoscopy, saline sonogram, hycosy, phalloscopy, and salpingoscopy. All these tests has to be done in day 7 to day 10 of the menstrual cycle, because why day 7 to day 10 is we are doing it in the post-menstrual phase. We are sure that the patient is not pregnant, and we are not disturbing an ongoing pregnancy also, because we are doing it in the pre-ovulatory phase. So out of which the primary modality which everyone use is the hysterosalpingogram. Here we inject a radio-opaque dye through the cervix and check the fill and spill of the tube under fluoroscopic guidance. The sensitivity of HSG is 84%, specificity is 75%. The main disadvantage of HSG is the pain. Every patient complains of pain after HSG. This is because of the release of prostaglandins after the radio-opaque contrast injection. And the second important thing is the radiation exposure. And the final thing is the false positive rate, which means if the tube is blocked in HSG, it doesn't mean that 100% sure that the tube is blocked. We need another modality to confirm the diagnosis. So the next outpatient test for tubal patency is saline sonosalpingogram. Here we inject the saline through the cervix, and we check for the uterine cavity and also the spillage of the saline in the POD. The main problem here is that we will not know the bilateral patency of the tubes. The presence of fluid in the POD indicates that at least a single tube is patent. The next test is hycosy, which is hysterosalpingo contrast sonography. Here, to combat the disadvantage of the saline sonogram, we are injecting a contrast material to see the individual patency of the tube. Here it can be the contrast which we are using can be an agitated saline, or it can be a contrast medium like Sonoview. Here they are seeing the patency of the tube. The complete patency can be seen with the contrast, and the other tube can also be visible. So individual patency can be seen with this hycosy. So in these sonosalpingograms, the sensitivity is 84%, specificity is 99%. And the main advantage is there is no pain as compared to HSG and no radiation exposure. But still, they require good surgical expertise, and there are inter-observer variability, and that's why it is not so very popular. And sometimes they are not very available. These contrast agents are not very much available, so that makes it less popular. The next most definitive test for tubal patency is laparoscopic chromoperturbation. So we inject methylene blue dye from below, and we look for the spillage of the dye under laparoscope. Not only that, we will be able to see in the same sitting the presence of any other adhesions or associated the tubo-ovarian anatomy and associated endometriosis. And even if it is present, we can correct it the same sitting. That is the main advantage of doing a laparoscopic chromoperturbation. The disadvantages are it is expensive, it is invasive, and it requires anesthesia. So the next other tests like phalloscopy and salpingoscopy, they are not very commonly done, but still just to know about it. The phalloscopy, under hysteroscopic, they introduce a fiber optic equipment, and throughout the entire length of the tube, and they check the mucosa, inner lining of the tube also in phalloscopy. The salpingoscopy also involves the same thing, but the only difference is in salpingoscopy, they introduce the endoscope through the fimbrial end. Okay, now after these tests, we have identified a tubal blockage. Now what are we going to do after this identification? We have to treat it. So how are we going to treat the blockage? Any blockage, blocked tube after this primary modality, we are going to go for a laparoscopy to check if the tubes are, what are the site of the tubal damage and also the extent of the tubal damage. Suppose if the tubal damage or the blockage is at the proximal end, then definitely we can try a tubal cannulation, because it can be a simple mucus or a debris which is causing it, or sometimes a corneal spasm can also cause this. So under anesthesia, under laparoscopy and hysteroscopic guidance, we can introduce an outer catheter through the tubal cornua and introduce a methylene blue dye under anesthesia and see if it is a simple corneal spasm, it might be relieved after anesthesia and we may get a patent tube. Even after that, if the blockage is not getting relieved, then we might need to introduce an inner catheter with a guide wire and give a gentle pressure on the blockage site and see if it is getting relieved or not. Even if it is not relieving after this pressure, then it indicates that it is a severe damage of the tube, and hence it cannot be, the procedure should be abandoned, rather giving more pressure, because there is a risk of tubal perforation with this procedure. The recanalization rates after tubal cannulation is 60 to 70%, but the pregnancy rates are only 22%. That is the cumulative pregnancy rate after 1 year. So there is a gross discrepancy. Though the patency is achieved, the patients are not able to achieve pregnancy. This might be because of irreversible deciliation of the endosalpinx. Sometimes this happens after an episode of infection. What is that? We know that it is a passage. The fallopian tube is a passage connecting the uterus and ovaries. Other than that, it has the ciliated epithelium, which helps in propulsion of the ovum towards the uterus and also the sperm towards the ovum. And there are certain secretory cells, which helps in secretion of certain nutrients and vitamins, which helps in nourishing the sperm and the ovum during the passage of it. So if any episode of infection is damaging this mucosa, though the patency is achieved, the pregnancy cannot be achieved. So mere patency of tubal lumen is not enough. Coming on to distal tubal occlusion. So if there is any hydrosalpinx or fimbrial phimosis, the most important thing which we have to look into is the extent of damage. If it is a filmy adhesion, mildly dilated tubes, thin walls, and the mucosal folds are preserved, then we can do a fimbrioplasty or a neosalpingostomy. Suppose if there is a fimbrial phimosis, we can remove the phimosis and avert the fimbrial ends and suture it to the overlying serosa, and also open the tube to relieve the mild hydrosalpinx. But again, the pregnancy rate here is 20% and ectopic pregnancy rates are higher. If it is a severely damaged tube with poor prognosis, this is according to ASRM. They are categorizing the people according to the extent of damage. If it is a dense adhesion, largely dilated tubes and thick walls and absent mucosa, it is better not to try surgery and go opt for IVF. Even in IVF, if the patient has ultrasound visible hydrosalpinx, better to remove the tubes before going for embryo transfer, because the fluid from the hydrosalpinx is embryotoxic and also cause mechanical flushing of the embryos after the embryo transfer. And another important condition is sterilization reversal. When a patient comes with a previous history of tubal ligation with the need of next pregnancy, we are quite skeptical as to opt whether for IVF or do another surgery. So how are we going to decide? It depends on the patient's age, the partner's semen quality, what surgical technique they have used in the previous surgery, how much remaining tubal length she has, and also where we are going to anastomose the tube in this surgery. So if everything is favoring the surgery, suppose if the patient is young, no other associated infertility factors, male factors normal, we are quite sure that previously they have done lesser, that is like Pomeroy's technique, they have not removed the entire tube or fimbriectomy is not done, then we are quite sure about it, then we can opt for surgery. Here we are doing a microsurgical technique by connecting connecting the remaining ends of the tubes in a 2-layer technique involving the muscularis and also the serosa with the interrupted sutures. The cumulative pregnancy rate after sterilization reversal is 65% with a high ectopic pregnancy rate of 8%. If any of this is abnormal, if the patient's age is older or any other associated male infertility factors are present, or we are not sure of the surgical technique involved, it is better to go for IVF. So we always have the debate whether to go for, in case of tubal factor, whether to go for tubal surgery or IVF. So what does evidence say? So this is in 2021, American Society of Reproductive Medicine have published this committee opinion. According to this, they have said that consider all these factors. If the patient is young age, the ovarian reserve is normal, her prior fertility their issues are normal, male factor is normal, so there is good surgical expertise, and the extent of tumoral damage is lesser, then go for tubal surgery. If any of these things is abnormal, better you opt for IVF. So the main advantage of IVF is it has good best cycle success rate. It is a less invasive procedure compared to a surgery. And tubal surgery, even if the surgery is successful, the patient can try multiple pregnancies also, multiple times. She can get pregnant more than one time. The main disadvantage of IVF is the cost, the risk of OHSS, which is very minimal now, and the risk of multiple pregnancy and complications in pregnancy like preterm, low birth weight, and IUGR. The disadvantages of tubal surgery is you need an expertise, and there is high risk of ectopic pregnancy and high risk of complications related to surgery as well as anesthesia. And even after surgery, if the patient is not conceiving, she might need IVF. So I want to conclude by saying always we have to look into the whole picture, not only the tubal factor, we have to take into consideration the age, the reserve, the male factor. And time to pregnancy is very, very important to consider. We have to take a shared decision making with the couple involved in the decision process. And the most important thing is patent tubes are not always functional. Thank you.
Good presentation, Dr. Janani. It was very crisp. I just want to add a point in the proximal causes for tubal factor. Tuberculosis is an important thing for proximal occlusion.
Yes, ma'am.
Tuberculosis have to rule out.
Yes.
And so you have elaborated on various investigations for tubal factor. Can you tell me which cases you will go for laparoscopic chromoperturbation and which cases you will go for sonosalpingography?
So suppose if there is history of any pelvic inflammatory diseases or any previous history of ectopic pregnancy, then already there is some kind of infection or infective pathology in the patient. So better directly to go for laparoscopy. If there is no other tubal infertility causes, or if there is no other previous history of any PIDs, pelvic inflammatory diseases, or ectopic pregnancy, then we can opt for HSG or saline sonogram.
In cases where you are suspecting endometriosis, first choice will be laparoscopy.
Laparoscopy, yes. Associated other infertility factors also.
And age factor also you should take into consideration when you are planning which modality you are going to decide.
Definitely.
It was a good presentation. Anything about like salpingitis systemica nodosa? What is it?
Yeah, salpingitis systemica nodosa is in the isthmus, there is some nodular thickening, which can be because of infection or muscular hypertrophy or some diverticulosis of the tube. Sometimes it can cause proximal tubal occlusion as well, which is very difficult to treat. In such cases, rather than correcting it, it is better to opt for in vitro fertilization in such cases.
But the other option is surgical, yeah, resection and anastomosis.
Resection and anastomosis, yes.
Yeah. So you were talking about the procedure, no, like a hysteroscopic cannulation. So you call it a selective salpingography. Okay. So the name you gave it on tubal catheterization.
Okay.
Yeah. Okay. Selective salpingography. Okay.
Yes.
And so otherwise, it was a presentation.
Is there any difference between tubal clipping and salpingectomy before IVF?
Yes, ma'am. Tubal clipping also can be done. Almost the results are same, but the problem with that is we have, suppose if the hydrosalpinx is still present, there is no place for the fluid to drain out. So the hydrosalpinx size might get increased and patient may have pain and abscess formation can be there. In salpingectomy, that problem is solved because the tubes are already removed. So that is the main difference in clipping and salpingectomy.
Any role regarding chlamydia antibody testing?
Yes, ma'am. Chlamydia antibody testing can also be done, but there are more false positives with chlamydia antibody testing, and there are cross-reactivity with chlamydia pneumonia infections, and we do not differentiate between persistent infection and remote infection. So it is not very much diagnostic and very specific about current infection. So not commonly used.
So when do you do actually women coming with, coming for fertility treatment? So when do you advise tubal testing? actually?
Yeah, we usually try it. Again, it depends on multiple factors: age of the patient, how many ovulation induction they have tried, how is the male factor. So
First time she's coming to you.
first time, if the patient is young, first time she is coming to me, I will definitely allow her for 3 or 4 cycles of ovulation induction. But before proceeding into IUI, I will definitely check the tubes.
Okay, Dr. Janani, it was good presentation. Thank you.
Thank you, ma'am.
Okay, we move on to the next speaker, Yuva speaker, Dr. Avanti. She has done her MBBS, MS, PDFRM in MGR University and DG at Germany and PGDMLE, MSc Embryology as well. Okay. She is a senior consultant in the reproductive medicine, ARC, Fertility Center and KG Super Specialty Hospital, Ganapati. Okay, so at Coimbatore. Over to you, Dr. Avanti. She's here to talk about the ovarian factors in infertility.
Thank you for the kind introduction, ma'am. I'll just start off the presentation. Is it visible, ma'am?
No, ma'am.
Yeah. So today I'm going to speak about the ovarian factors in
Please
infertility.
share your slides.
Not yet visible.
You're unable to see your slides.
Okay, ma'am. 1 second.
Please click on share option, ma'am.
Yes, ma'am. I've done that. Now, ma'am?
No, ma'am. After that, also again, you need to click on share button.
1 second, ma'am. Yeah, sure. There's some issue, ma'am. Just a second. Now, ma'am, is it being shared?
No.
Please open up your PowerPoint.
I did open, ma'am.
And then come to Zoom, click on green color share option. And then again, there will be blue color share option. Then you need to click on that.
Now I think it's been shared, ma'am.
Yes, ma'am. Now we can see, ma'am.
Yes, yeah.
Please make it a full screen. Thanks, ma'am.
Sorry, ma'am. Sorry for the inconvenience. So today's topic is ovarian factors in infertility. And we can see that female factor of infertility is around 30%. And when we see exclusive female factors, we can see that around 35% is ovulatory dysfunction, 20% is diminished ovarian reserve, and 10% is endometriosis. Now that the whole marathon is about endometriosis, I would just like to discuss about the ovulatory dysfunctions. And so before we go into it, let us just see the role of ovaries in reproduction. So all of us know that from the hypothalamus, the GnRH is being released, that is gonadotropin releasing hormone, which acts on the anterior pituitary to produce FSH and LH hormone, which would act on the ovary, which would help in the growth of the follicles. And as the follicles grow, there will be the production of estrogen. Estrogen will help in endometrial thickening. And this is how, once the ovulation occurs, there will be fertilization and then implantation. And this is how ovaries are very important. So, at the overview of the ovarian dysfunction, it could be anovulation or oligoovulation, which we see in PCO or hypothalamic amenorrhea. Then the second would be the diminished ovarian reserves, which are age-related or iatrogenic. Then we have the premature ovarian insufficiency, which could be genetic, autoimmune, or idiopathic. Then we have the luteal phase defects, that is because of the inadequate progesterone secretion. And then we have the surgical or the oncological damages, that is when oophorectomy is done or the patient undergoes chemotherapy or radiotherapy. So we have the WHO classification for ovulatory disorders. This has been the classic classification for a very long time. We have 4 groups. The first group would be hypogonadotropic hypogonadism, where we have the low FSH and LH production, and which would lead to low estrogen levels. This
We cannot hear you, ma'am.
Slide is also not moving.
Avanti, ma'am. Avanti, ma'am, are you there?
What happened, Sagiti?
Avanti, ma'am, has lost her connection, ma'am.
ராதிகா அவளை இன்னொரு வாட்டி லாகின் பண்ண சொல்ல.
Avanti, ma'am.
ஹலோ, ராதிகா, காயத்ரி, கார்த்திகா.
சொல்லிடுறேன் மேம். இந்த சொல்றேன் நான். அவந்தி கிட்ட சொல்லிடுவோம் மேம். we will call her.
அத கால் பண்ணி திரும்ப லாகின் பண்ண சொல்ல. அப்படி இல்லைன்னா அப்டேட் போக வேண்டியதுதான்.
இந்த வரேன் மேம். ஒரே நிமிஷம் கூப்பிட்டு. சொல்லிட்டேன் மேம். இந்த வராங்க.
ஓகே.
Sorry, ma'am. Hello.
வந்துட்டாங்களா?
Avanti, share your screen.
Sorry, ma'am. It's
No issues, come on.
Where did I skip, ma'am? From the treatment part or?
Where I think causes only.
Ovarian factors you are listing it.
Classification. World Health classification was there.
Yeah.
This one, FIGO classification.
The previous.
So, this slide, ma'am.
The previous one. Stop there.
Here, ma'am, WHO classification.
This one, yeah.
Yeah, correct. This was.
Sorry, ma'am. So, WHO classification, we have group 1, group 2, and group 3, and group 4. Group 1 would be hypogonadotropic hypogonadism. That is, the FSH is low, LH is low, and estrogen is low. Idiopathic Kallmann syndrome, or functionally for the anorexic woman who exercise more, stress, and weight loss. Then we have the iatrogenic drug suppression and pituitary disorders like Sheehan's and tumors. And type 2 is typically our PCOS, where we, FSH is normal, LH is normal, and estrogen is also normal. And group 3 would be hypergonadotropic hypogonadism, where there is high FSH and LH and low estrogen. So in this, it could be the genetic causes like Turner syndrome, autoimmune ovarian failure, infections like mum oophorytis, and iatrogenic surgery, chemotherapy, radiotherapy. Then type 4 would be the endocrine disorders, the other ones like hyperprolactinemia, congenital adrenal hyperplasia, and androgen tumors. So to work it up and classify into this, we need the hormonal assay, that is FSH, LH, estradiol, AMH, prolactin, and testosterone levels. On ultrasound, we need AFC count, antral follicle count, ovarian volume, and karyotyping, genetic testing, and MRI. And then FIGO in 2022 has given its updated version of the classification, that is HypoP. So they like giving the fancy terms like palm coin, and now they have given gain, fit, pi, and they have divided it into hypothalamic causes, pituitary causes, ovarian causes, and PCO was given a special status. In type 1 hypothalamic, we have the genetic, autoimmune, iatrogenic, and neoplasms. Type 2, we have functional, infectious, and inflammatory, trauma, and vascular causes. Type 3, we have the physiological, idiopathic, and the endocrine causes. So let us just look at the treatment options. The first group would be hypogonadotropic hypogonadism. So in this, we have the non-pharmacological therapies, like we encourage the woman to gain weight more than to get to the normal BMI of greater than 18. Then if they're intensely exercising, we ask them to
full screen.
Okay. So, so we would ask them to reduce the intensity of exercises. Then we need to address on the physiological stress and eating disorders. Then we encourage them to go for the cognitive behavioral therapies. Then we have the hormonal replacement therapy, that is estrogen and progesterone. Then we have the pulsatile GnRH therapies. And in the supportive therapies, we have calcium plus vitamin D for bone health. Then the DEXA scan to monitor the bone mineral density. Then MRI brain to look for any organic lesions, the suspected ones. Then we have a newer kid in the block, that is kisspeptin analogs in stimulating GnRH secretions. This has been worked on much, and this is a newer one where a lot of research is happening. It's a neuropeptide which can stimulate GnRH secretions. So it can induce FSH and LH, then it can promote the follicular growth, and then it's used in hypogonadotropic hypogonadism conditions. Then it's used as an alternative to HCG trigger in ART to reduce OHSS in PCOS patients. It mimics the physiological GnRH regulation. But then all this is still in the experimental stage, and once the RCTs and we have even enough evidence, we would start off with it. Then coming to the group 2, normogonadotropic normogonadism, where this is a normal thing. This is our PCO. And all of us know the treatment for this, that is lifestyle modifications. First line would be reduce weight. and weight loss and diet, then we can, for when the first line of treatment fails, we go to the second line of treatment, that is PCO drilling in resistant CC cases or very high LH levels. Then we have ovulation induction. Excuse me, ma'am, somebody's mic is on. Can we just turn it off, ma'am? So the first line of treatment in PCO would be the lifestyle modification, and then it would be the letrozole and clomiphene citrate. If this doesn't work, we go for gonadotropins with the adjuvants of metformin and myoinositol. If these fail, we go to PCO drilling in resistant cases and when there is high LH levels. If all this fails, we go for the very classic IVF or ICSI, and hormonal contraception can also be used. The newer treatment methods, again, the same thing, insulin sensitizers like inositol and GLP-1 receptor agonists like liraglutide and semaglutide. Then adjuvant therapies can be given, and ovarian rejuvenation also can be tried in this. And coming to the group 3, this is the more important group because hypogonadotropic hypogonadism, for a very long time it was thought that the only way to treat this condition would be by oocyte donation, but then we have many other alternatives now. The first thing would be the ovarian rejuvenation techniques, that is PRP, stem cell therapy, and in vitro activation. In vitro activation is nothing but we laparoscopically remove the ovarian cortex, then look for the follicles in it. We have to use the hippocampal hipposignaling pathway, activate it, and then activate the follicles, and then reimplant into the ovary. This is being done in Japan and China, and the results have been quite mixed. Then we have the artificial ovary. Now they're working on the bioengineered 3D scaffolding, and there's a lot of work going on in genetic and epigenetic advances. And the future fertility would be like we can do the cryopreservation and reimplantation like in cancer patients, then in vitro follicle maturation, and artificially make the gametogenesis using the induced pluripotent stem cells. Then the take-home message would be, we know that the dysfunctional ovaries contribute around 35 to 40% of female infertility. Then we have the classic WHO classification and the recent FIGO hypo-P classification. Kisspeptin is a neuropeptide mimicking the physiological GnRH regulation, and there's a lot of research happening in this field, and it looks very promising. It can be used in hypogonadotropic hypogonadism to restore the GnRH pulsatility, used as an alternative to HCG trigger to reduce the risk of OHSS in PCO patients, and potentially more cost effective than gonadotropins. Then in hypergonadotropic hypogonadism, where oocyte donation was the only option, we have many other newer advances like ovarian rejuvenation, artificial ovaries, and genetic and epigenetic advances. Thank you.
Good presentation,
Sorry.
Dr. Avanti.
Sorry for the glitch, ma'am. I think next time I'll join from home. There's been very poor network. Sorry, ma'am.
Okay. So you have the ovulation induction drugs. Which drug will you prefer to give in a patient with PCOS?
Ma'am, we are starting off with letrozole because we are aiming at the monofollicular growth. When we want multiple follicles, clomiphene would be a better drug.
What is the disadvantage of clomiphene over letrozole?
Ma'am, clomiphene would reduce the endometrial thickening and anti-estrogenic effect.
Okay. What is the role of ovarian drilling? Present role?
Ma'am, present role is not much, ma'am, unless they fail all the first line treatments. That is, after we try the ovulation induction and after we have given the gonadotropins and with very high LH levels, then we are just doing the mild drilling, ma'am. That is just 4 follicles. We are not doing extensive drilling of late.
What is the indication? That's what.
Indication would be very high LH level and failure of first line of treatment. that is CC resistant, clomiphene citrate resistant women, and when they're not even responding to the gonadotropins.
That's what if gonadotropin is now equivalent for drilling. So in CC resistant cases, we can go for gonadotropin rather than drilling.
What is the disadvantage
if they fail to respond to gonadotropins as well, that is when we are suggesting drilling.
Maybe in some of the patients in whom suspect some other pathology, like whenever there is additions or something, when you do it, maybe as an adjuvant we can do that, but as such, drilling, the disadvantage of drilling is adhesions, right? So that is what
adhesions, ma'am.
important.
And in the longer, okay, ma'am. Sorry, ma'am. In the longer run, we are seeing that there is decreased ovarian reserve, ma'am.
Yeah. So that is what is there. What about the role of prolactin? You haven't mentioned about thyroid and all those stuff.
Ma'am, endocrine part, thyroid and prolactin are like they would be acting on the FSH and LH and GnRH. So that would actually that comes under the type 1, WHO type 1 dysfunctions. The
So when
endocrine
do you
causes.
check on that?
At the first visit, we do check for the prolactin and thyroid levels, and we try keeping them in the normal level. And prolactin level should ideally be checked in the mornings. So if at all we are doing it randomly in between the day, if it is coming high, we are again repeating it the next day, ma'am. Next day morning, we are repeating prolactin. And then if it is high, we are starting them on the therapy.
Ovarian factors as such is a big topic. I think you
Yes,
most of the advanced technologies in ovarian factors rather than the basics. Okay. So anyway, it was a good presentation. Any further questions?
No, ma'am.
Okay. Thank you. Overall, it was a good presentation by both the speakers. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. So shall we move on to the next session? Thank you, Shanti ma'am. And thank you, Kartika ma'am.
Thank you.
Thank you, ma'am.
Thank you so much.
So
we'll move on to the next session. We welcome Dr. Chandra ma'am, who has done her UG and PG from Government Stanley Medical College. And she's a gold medalist. And she started the first laparoscopic and IVF center of her district in Namakkal. And she delivered the first IVF baby and ICSI baby of her district.
Thank you. Thank you, Dr. Radhika.
Yes, ma'am. She's a member of IMA, ISAR, Images, IAGE, PCOS Society. And she's a FOXY member from 1982 and founder president of Namakkal Women Doctors Association and founder president of Namakkal OG Society, EC member of TNFOG, registered ISAR faculty. And she's a faculty in many national conferences. Awards, she's won NEMA Best Doctor Award, Best Women Achiever Award, Best Fertility Consultant Award, ISAR Dronacharya Award in 2023. Very proud of you, ma'am, and welcome.
Thank you. Thank you for the nice words.
Ma'am, can you please introduce Dr. Priya Kannan?
Yes, very much. I'm extremely pleased to introduce Dr. Priya, and she's an embryologist from Garbharakshabige Fertility Center, Chennai and Trichy. And she's a secretary of IFS Tamil Nadu and secretary of IMA Chennai, Kodambakam. And she's the district coordinator, Chennai IMA Nursing Home Board, Chennai. And she is the past president of ACE India. And areas of interest: cryobiology, reproductive genetics, recurrent pregnancy loss, and a spot. She is the daughter of Dr. Jayam Kannan, and she is well known. And welcome, Priya.
Thank you, ma'am.
Platform is yours.
Thank you, ma'am. Thank you so much for the kind introduction, ma'am. And I'll just start sharing my slide. Yes.
Priya,
Yes,
you
ma'am?
start with the embryologist today. When is that embryologist day? Please mention and start, Priya.
Okay, ma'am. Sure, ma'am. At the outset, I would like to thank TNFOG and in particular Sampath ma'am for the invite to speak today. And ma'am had given me the topic recent updates in embryology. I'm not able to cover everything, but I'll give a gist. And just to start with, as madam said, this month is the Embryology Day. On July 25th is when Louis Brown was born. So that is our Embryologist Day. And also IVF Day, you can call it. So we all celebrate it quite nicely. And I thank Madam again for giving me the invite to be a part of their celebration in Oxy on that very special day for us. And so with that, I'm just going to give a very brief update in embryology and andrology, some of the crux of the recent updates that we've had right now. Before I go into that, I would like to mention who can be an embryologist in our country right now. I think that is the most recent update that we have in our country. So these are all the only people who can be an embryologist right now, who has had a PG, that is an MSc in clinical embryology, which has to be a full-time program with 4 semesters, and they must have at least 3 years of experience after the course, a PhD with a full-time project in clinical embryology with 1 year experience, an MBBS or a veterinary science with 2 years of experience after a full-time clinical embryology course, and PG in biotechnology or life sciences, one year on-site program with 4 years of post-course embryology experience. And there was also one-time measure as given by the ART law. So this is there in the ART law, but this is an amendment that came around later. So this is the most recent and the update that we all have to know in our country before we go into the science. And now coming to the actual science itself, there's been quite a number of updates or recent developments in embryology right now. One of the most important things I'm just going to list are the improved embryo culture systems. Of course, the pre-implantation genetic testing that we have been extensively using now. The update that we could have around in the recent times and in the near future is the use of artificial intelligence in embryo selection, automation and robotics in embryology, and of course, the emerging trends to the really future would be the in vitro gametogenesis, mitochondrial replacement, CRISPR, etc., etc. Let us start with the basics. So embryo culture system is at the heart and is the foundation of any embryology lab. So what are the, apart from all the established procedures that we have, the recent updates or the changes that has come around and is going to be probably universally accepted in some time is A, physiological oxygen concentration, the single step media that we've been using extensively, time-lapse imaging systems, and hence with the combine of all this, a shift to a only blastocyst culture and eventually single embryo transfers. And before I start, everybody, who are listening, it would be a great if we can all go through this paper, which was published recently in the RBM online, which is a good practice guidelines of clinical embryology, which was in recent publication in 2024. And that covers all the topics that we need to know about in the IVF lab, from organization until the introduction of novel techniques. It is a good read through and to be established in our laboratory practice. Now, coming to the physiological oxygen concentrations, traditionally we've been using only the air concentration, whatever is in the atmospheric air, which is around a lot of oxygen concentration. But then we know that an increased oxygen concentration causes a generation of reactive oxygen species, which in turn causes damage of cells and disrupt embryonic development. Previous studies have assessed oxygen concentrations in the fallopian tubes and even in the uterus, and it was found to be somewhere between 5 and 8%. And so when we are trying to mimic what is in vivo, then we start thinking, why not introduce 5 to 8%, which is a physiological oxygen concentration the embryo is exposed to in our in vitro systems as well. And that is how this thought came around. And eventually, Many meta-analyses have indicated a potential benefit in favor of low oxygen concentration. Though the data are considered to be of low methodological quality, still it has been considered that necessarily, and we all know by a lot of publications, even though we are waiting for more RCT and meta-analysis, that when we want to go for blast culture, a low oxygen concentration definitely benefits the embryos, and we have better top quality embryos on day 5. And the next one is our PGT, that is pre-implantation genetic testing, which we had as PGS and PG, pre-implantation genetic screening and testing before, diagnosis before PGS and PGD. Now it has been renamed as PGT in terms pre-implantation genetic testing, of which we have 3 types: PGT M, SR, and A. M is for monogenic disorders, SR stands for structural rearrangement, and A is for aneuploidy. We will start with the PGTM because PGTM and SR are 2 objective indications for doing PGT, that is pre-implantation genetic testing. What all can we assess in what all can be, who are all the indications we can use PGTM for is A, monogenic disorders. If we know there is a familial trait of monogenic disorders, including BRCA gene, we can test for that in the embryos. But then, unfortunately, we cannot test many, polygenic disorders there, but we can test for monogenic disorders. We can also test for, it can also be used for mitochondrial diseases and HLA typing also. But we have to understand that the particular gene that we are looking for should have to be able to be associated or seen or tested and separated at least in the parents, and that is when we can look for this. And PGT-SR is structural rearrangements when any of the parent have pathological rearrangements such as reciprocal translocation or Robertsonian translocation, inversion, complex translocations, or any pathogenic microdeletions and microduplications. The same can be tested in the embryos. As you know, embryo biopsy is done, and we give 5 to 10 cells from the trophectoderm, and that is all they can test. So like how we do in the blood test, we cannot do exome sequencing there. Whatever we are doing, it has to be extremely targeted. And hence, monogenic disorders and structural rearrangements are absolute indications when you want to do PGT. Now coming to the next one is PGT-A, or testing for aneuploidies, where we look at all the chromosomes and screen the chromosomes for any problems or aneuploidies. However, I would like to mention that whenever we are doing PGT-A or M, PGT-M or SR, PGT-A is also done. So in that terms that it is also a screen. Along with that, a monogenic disorder is looked for, or a structural rearrangement is looked for. But those are objective indications. When we are doing PGT-A, as who all can we look for? We must know that what is the science behind it. When we are doing for aneuploidy screening, can it be done for all? PGT-A for all has been a fad for some time, but let us look at science to see who actually benefits from it. There's been RCT which has shown that the ongoing pregnancy rate per embryo transfer was significantly higher in PGT-A group than in the morphology group, only for patients aged 35 to 40, and it was not for those with less than 35 years. And it was done by none other than Santiago Mune, who was there in PGT-A, the PGS1. That is when we are doing using fish and everything. We have lots of publications from him. He is one of the godfathers of pre-implantation genetic testing. None other than them. They had a huge RCT done on this. And there was another RCT which revealed that in an IVF population aged between 20 and 37, the cumulative live birth within 1 year of PGT-A group was even lower than that of morphology group. So ideally, PGT-A is probably indicated for the advanced maternal age and not for the younger age group. So that brings us to who are all benefited. So who should be recommended for? A, for advanced maternal age, that is aged above 38 and above, recurrent miscarriages, recurrent implantation failures, and unexplained severe teratozoospermia. Probably these are the 4 indications where the publications and science have shown that PGTA, it can be recommended and will be useful for the patients. When we should not do PGT. PGT should not be offered without a definitive genetic disease diagnosis or positioning information for the disease-causing locus. When we don't have information, we cannot do PGT, or we should not offer, because maximum number of cells I give when I do a embryo biopsy is 5 to 8. That's all the number of cells we'll be able to take from a trophectoderm and give it. And nowadays, we don't do PGT on usually cleavage stage at all. We do only in the day 5 or the blastocyst. So the trophectoderm cells, we are able to give about 5 to 8. And so the amount of genetic material that is available for testing is quite limited, and hence a definitive genetic disease diagnosis is mandatory before we even recommend for PGT. And it must not be used for selection of non-disease trait such as appearance or height or skin color, such as those traits. Coming to the other 3 parts which we have mentioned, the artificial intelligence and embryo selection, this has been an ongoing process. For example, like there are many AI systems that are being tested right now, and that in association with the time lapse system probably can give us better embryo selection. This is in the process right now. We don't have dogmatic evidence or some system which say, you use my system, it probably is better. All these are under study right now, and we hope, and I really hope, we would be happy to grab with both our hands any way that we can have a better embryo selection with which the implantation rates for the patient will definitely go up. Automation and robotics, we are definitely looking forward to automation and robotics, let's say in terms of ICSI or freezing. There are automated systems for freezing and warming already, though they are not very avidly used. They are still there. I think it will be more refined probably in few years to come, and we could have a lab on a chip, which is already a concept, where you put an egg in there and then some sperms, and everything happens from denudation to ICSI to culture to freezing happens on a chip. It is probably bound to happen in some time. Apart from this, apart from the technology, more on the science part is the in vitro gametogenesis, where we should be able to have, we should be able to make sperms in the lab, which has been a possibility in some very rare occurrences. Probably that can happen, and maybe oocyte as well, which seems like a very long drawn thing, but it is something that we are looking forward to. Mitochondrial replacement therapy, which was used earlier, which probably could be refined in the future. The use of CRISPR.
Hello, Dr. Priya. Hello.
I think we have lost Priya, ma'am.
Yes.
Shall we
slide
call her? I'll call her, ma'am.
Slide அதே தான் இருக்கு.
I'll give her a call, ma'am.
Okay.
Dr. Priya's power, there's been some power circuit problem there. She'll be joining very soon. Let's all hold on for a second or two.
Okay.
காயத்ரி ஆஷாராவ் இருக்காங்களா?
Hello?
Yes. Yeah, you are audible.
Yes, ma'am. Yes, ma'am. Sorry, there was a power. Suddenly they got disconnected. So my connection went off, ma'am. Sorry.
Okay. In between, we'll okay, it has come.
Thank you, ma'am. Thank you for the patience. We do have some signs probably coming in as well. But then let's look at certain things which has definitely made a difference in embryology, which we should never forget, which I've not mentioned, are the improved culture systems, which is like the single step, and then probably the vitrification, which has made the market change in the embryology. Everything else is on paper. What I've mentioned, that is artificial intelligence, automation, those in vitro gametogenesis or mitochondrial replacement therapy, they're all on paper. We are yet to see any of that. But few things that has definitely made a change is improved culture systems in terms of single step media and vitrification. These are the only two things that has definitely made a difference in the practice of embryology, which has benefited patients in a huge way. Now, I shouldn't forget that there has been some changes in andrology as well, and I would like to mention that. And I hope and urge all of us to download this 6th manual of WHO manual and go through it. And if we can have a different lecture again on all what it has changed in our practice, though not much of, but then it has done. So let's going to the advanced methods of sperm selection. I'm just going to mention few sperm selection methods which could probably make a difference, such as the PIXI. The PIXI dish is something we've been known about. We have not, we've been using it some time, but then we did not see much of a difference. So we restricted using it. But now there's been lots of studies which has shown that the sperm selection using PIXI may probably decrease the miscarriage rates as compared to standard ICSI. And hence, this can probably be used in patients with the recurrent recurrent pregnancy losses and can probably help them. And microfluidics is something which we've been talking about using for the past 10 years, extensively used without knowing how much it benefits our patients. Now, with all the publications, it has there's been a thought that microfluidics probably provides higher number of top quality blastocysts. Oh, again. Top quality blastocysts as compared to the DGC and other methods as well. Coming to zeta potential, which is a sort of a, let us say, a theoretical thing, but it is a technique that compared to the continuous, that is the gradient method, it can give us the sperms with less DNA fragmentation. And ICSI, the pregnancy rates following this using zeta potential with DGC probably is a better procedure, but it is sort of a not very practically used procedure because of its lower efficiency. However, coming to Cochrane, despite all the methods that we know, unfortunately, none of it has improved the pregnancy rates. Though we seem to have one, in subset, it could have some effect, but it does not improve any pregnancy rates. And one word to mention about the sperm DNA fragmentation, which we've had since 2007, 2008, we've been regularly using. What I would like to mention, which is based on all the guidelines that has been given right now, is that it is not to be recommended for routine use in all infertility evaluation. Sperm DNA is a very specific test which should be probably used when there is unexplained infertility, when there is recurrent pregnancy loss, when there are male patients with risk factors, or after repeated failed IUI, IVF, or ICSI. And it is not to be used regularly. And what is the improvement that we've had when you have extreme low concentration of sperm, such as testicular sperms? Is there a possibility of single sperm cryopreservation possible? Yes, there are so many leaflets, so many biological and non-biological carriers available.
Please.
However, sperm DD is something that we can use. It is commercially available. It seems to be one of the most simpler thing, though quite expensive. But when it is a possibility to freeze sperms singularly, you can have one sperm per the VD and freeze it, and the recovery rate is quite high. If we can have the technique to do it and the affordability of the patients, that also has shown to be possible right now. So we are looking at clinical judgment, best evidence, and the patient values. And whenever we are looking at newer introduction into andrology or embryology, we look at efficiency, the cost, because it should be affordable to the patient, and the quality. Are we actually improving the success for the patient or not? That is something we always have to keep in the mind. And thank you again for this wonderful opportunity. And I apologize again for the break in between, because I lost connection because of the power shutdown. Thank you so much again. And I'll be very happy to take any questions.
Wonderful presentation, Priya. And having come all the way, while we were using, in the beginning, we were preparing the media and all. Nowadays, the ready-made medias are available. And as you correctly said, it has made us happy.
Huge
and
difference.
success rate. Yeah, and vitrification. From slow vitrification to present vitrification is excellent. But all these researchers and so much expenditure are spending on this recent advances in embryology. Have we achieved any improvement in the success
Pregnancy
rate?
rates.
Yes.
That's $1 million question, ma'am. Ma'am, I think the few things that has actually resulted in improvement of success rates is the improved in culture systems. That is, we have gone from the big incubators to the small benchtop incubators. So we don't disturb undisturbed cultures and better culture media. They are evolving culture media. These two are the only ones that has actually improved our pregnancy rate, ma'am. Neither PGT nor anything has improved our pregnancy rates. And of course, when we can vitrify and we can have a 99% recovery of the embryos because of vitrification. Earlier, we were used to do fresh transfer because our slow freezing results were abysmal. So now we have the confidence to say you freeze with the endometrium is poor, please freeze the embryos. We can confidently give you the embryos back. And that is one thing that has improved the cultures, ma'am. Now with the good blastocysts coming and very good vitrification, in younger patients, we have moved to elective single embryo transfers, which has given us about 40-50% success rate. So I think that is something we should be looking forward to, because especially when we know that it has been a dictum that having multiple pregnancies is considered a complication. We should ideally have elective single embryo transfers, for which blast culture is probably essential.
Okay. And what is the cost of the single sperm freeze?
Ma'am, that alone costs about 25,000, ma'am.
Okay.
And that too, we have to do ICSI into it. So that cost additional your ICSI things, needles, and then your expert to sit and do it. So it's quite an expensive affair. But then if somebody is very particular about having their sperm and frozen and do it, then we can do it, ma'am. I mean, that is a possibility. We didn't have it 10 years ago, so we are having it now.
Thank you. Thank you very much.
Super, Priya. Wonderful talk.
Thank you, ma'am. Thank you so much.
Priya, as usual.
Dr. Priya, one more question. This is Dr. Pongodi Selvaraj.
Yes, ma'am.
Hello.
Yes, ma'am. Please, ma'am.
And for embryo culture, we use only CO2 incubators for more than 10 years. We are using that. Even our blastulation rate is also good only, and we get a good success rate, and so many pregnancies have happened and delivered also. So is it important to use only the trigas for culturing embryos, or is it okay with the COT incubators also? We have 2 or 3 Heracil incubators. Our embryologist, he insists only on this incubator. Actually, he doesn't want us to spend more on other things. So, but we are getting results with this. So what is your take on this?
Congratulations on your good results, ma'am. Ma'am, something that the trigas or the low oxygen concentration is a concept that is being introduced. Yes, there are many publications that probably, ma'am, if you use a trigas, you could have more top quality blastocysts. If you have 10 eggs and you are having 6, 8 cells and about 3 to 4 blasts, probably by using trigas, you could have that 5 blast. So your number of top quality blasts can increase, which means you have more cryo-preserved embryos, which means more attempts of embryos. Your cumulative pregnancy rate may go up. If you are having a good pregnancy rate now, they always we look to, like, ways of improving that. Probably you could have more pregnancy rate. If you're having 40% now, you could go to 45, 47% with trigas. So
So
that is
then
how
you
we are
suggest me
looking
to
at.
buy trigas incubator then. Okay.
Ma'am, you could try it. You can get a trial for a month, see how it works. And then you definitely, ma'am, we are always looking to improve results, ma'am. It is not that you want to be static. So if you are having, like, very good results, you could improve. You can try improving it, ma'am.
Okay. Thank you. Thank you.
Pleasure, ma'am.
Okay, I think we can. We'll be having more and more doubts only. I had the same doubt of what Dr. Pungori also had, because we were getting results, good results with carbon dioxide incubator, but now we are trying for this trigas also, as you said, to get more improved results.
Yes. Ma'am, there are also systems where you can have a CO2 and a nitrogen separately. You don't have to have a trigas. So that type of incubator, you can set your oxygen to 5, 6, 7. You can try that. I mean, all permutation combinations are available. So, I mean, you just have to look around.
Okay.
Radhika, can we move on to next?
Okay. Thank you, ma'am. Thank you again for the opportunity.
Yeah. Thank you very much.
Now we come to the last part of our marathon CME, which is a panel. And this
we
panel,
have our panel discussion, wherein we invite
Radhika madam, go ahead.
Asha ma'am. Dr. Asha ma'am.
Yeah, I'm here. Can you just share my slides and check?
Hello.
Hello. Dr.
Welcome, Dr.
Asha
Asha ma'am.
Can you hear me?
Yes, ma'am.
Is it my voice clear?
Yes, ma'am, your voice is clear.
Okay, fine. Okay.
We all know a famous Dr. Asha ma'am, who is the director of Rao Hospital and Care in Coimbatore. She's a director for postdoctoral fellowship program in reproductive medicine and endogynecology, and she's affiliated to Tamil Nadu Dr. MGR Medical University in Chennai. And she is the chairperson endometriosis committee FOGSI between 2020 to 23 and organizing chairperson UA FOGSI South Zone 2019 at Coimbatore, past president Coimbatore Obs and Gynae Society, and organizing chairperson Endo Insight 2021 International Endometriosis E-Congress with FOGSI and SEUD, and organizing chairperson IAGE Star Endogyne Conclave 2019. And organizing chairperson for the 8th National ISAR Conference in 2001. And she's done lots of publications and research, editor for FOGSI Focus on Endometriosis in 2023. And she has received gold medal from President of
that's
India.
Okay. I think we all know each other very well.
Yes, but you are an inspiration to all of us.
Thank you.
Thank you, ma'am. Welcome, ma'am. And I will shortly introduce our panel members. We welcome Dr. Shanmugha Vadivu. She's the professor of Department of OG, Common Mohan Kumar Mangalam Medical College Hospital in Chennai. And she has been the past secretary of Obs and Gynae Society of Salem. Next slide.
Thank you, Radhika.
Yeah, welcome. We welcome Dr. Rekha Rajesh, who is a clinical director, Vijay Shrishti Fertility Center, Hosur Krishnagiri, Tirupattur, and director of Matrutva Fertility Center, Tirupati and Nellore. Welcome, Dr. Rekha Rajesh.
Thank you.
And we welcome Dr. Pungodai Selvaraj ma'am, who is a gynecologist, laparoscopic surgeon and fertility consultant, managing director of Divya Hospital, Bhavya Fertility Center, Tirupur. And she is the founder president, Tirupur OG Society, member of ISAR, FOXC, PICO Society, and Yeshre. Faculty National Regional Conferences. We welcome you, ma'am.
Thank you, madam.
Then other panel members, myself and
Radhika Gauri, I am introducing you. You are the permanent MOC of TNFOG. Yes.
Thank you, ma'am, for the opportunity. Thank you, ma'am.
Only 4, Radhika, 5 is there, no?
Yes, ma'am. One more person is there. I will just check, ma'am.
Tamil Selvi?
Good evening, Sampath, madam.
Yes, Dr. Tamil Selvi, ma'am.
Good evening, Tamil Selvi.
Good evening.
Fellowship in, she's done the fellowship in reproductive medicine, and she's an EC member, Trichy OG Society, Trichy chapter of Tapisar, life member of Triogs, Foxy, ISAR, IFS PICO Society, and she's presented papers in AACOG, UA Foxy, National ISAR, and Fertivision. Welcome, ma'am.
Thank you.
And we will start.
Okay. Now, madam can start. Asha, madam can
Dr.
start.
Sampath, at the outset, I'm very happy to see, happy to hear Dr. Sampath Kumari's voice. I thought she may not be able to log in, but she has promptly logged in. We're always energized and inspired by you, Dr. Sampath.
Yes,
and,
madam, yes.
Much honored to be here at this platform, invited by you. Thank you so much. And very warm welcome to all my panelists. Let me just try to share the PPT. Share button. Zoom le poi parunga. Yeah. Ida ange last ponuma idu ponuma. Ange Sampath Kumari venda. Idu illa idu. Yeah, can you see my slides?
Yes,
ma'am.
Yeah, it's moving. Yeah, okay. Very happy to be here today and discussing endometriosis and infertility, which is very close to my heart. And we know that world over 200 million women are suffering from endometriosis. And of these, more than 30 million women belong to India alone. And it causes severe dysmenorrhea, chronic pelvic pain, and infertility in about 30% of women. 1 in 10 women of the reproductive age group are affected by endometriosis. And 30 to 50% of women with endometriosis have infertility. And all of us know about the chronic inflammation that it causes, resulting in impaired decidualization, DNA damage to oocytes, sperm endometrial cell, inhibits sperm motility. It causes a toxic peritoneal cavity, and there is problem at every level, right from pituitary ovarian axis, anatomical distortion of the tube, tubal block, and can affect the oocyte number and quality, sperm function, endometrial receptivity, defective corpus luteum. It's a disease of estrogen dominance and progesterone resistance. And according to ASRM, endometriosis should be viewed as a chronic inflammatory disease that requires a lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedures. Because in my days, as we have seen that endometriosis was always a surgical disease because we had to do laparoscopy or laparotomy my days to do for the diagnosis, management, etc. And gradually, today we see that it is imaging for diagnosis and laparoscopy for management. So we have to avoid doing surgery as much as possible. And aim of the treatment is to alleviate pain and promote fertility, reduce the recurrence, and improve the quality of life of the suffering women. And along with endometriosis, adenomyosis is also on the rise. 21% of women with endometriosis concomitantly had adenomyosis. 28% of subfertile population has adenomyosis alone. So whenever there is problem of endometriosis, think of adenomyosis also. And if you miss out on adenomyosis, your implantation results and obstetric outcome, everything can suffer. Because today adenomyosis is not a disease of Paris and 40. It is seen more and more in younger women and women who are infertile. So coming to case-based scenarios in infertility, let us make it a simple discussion, simple and realistic rather than high-flying. So Mrs. X, 24 years old, married for 2 years, regular cycles with mild dysmenorrhea, no other complaints, ultrasound normal, and normal semen analysis. So she comes to you with infertility of 2 years, and how will you help her? Dr. Shanmuga Vedivu.
Hello. I will, since this HSG is normal or cycles are regular with mild dysmenorrhea, and there is no evidence of endometriosis as per the investigations, I will go with the ovulation induction, ma'am. With I will check her previous records if she has undergone any, how many cycles of ovulation induction she has undergone, and IUI has been done or not. Based on that, I will go with my management.
Yeah, so she sounds more like unexplained infertility. Do you suspect endometriosis in this lady?
The mild, she's having mild dysmenorrhea, so I do suspect, ma'am.
Yeah, because in endometriosis, sometimes there is no correlation between the symptoms and the real disease.
And disease.
People with mild disease can have lot of symptoms, and people with lot of disease can also have minimal symptoms. So it's very important to always think of endometriosis. So in my year, it was our motto was think endometriosis and fight endometriosis. Always think of it, because the disease and the burden of the disease may not really correlate. So whenever you come across even unexplained infertility, think of endometriosis. So how will you, yeah, you're right. You said you will do the induction of ovulation. Does anybody want to do what?
Ovarian reserve test I would like to do.
Yeah. What are the other tests we may like to do, Dr. Pungode?
I would like to do ovarian reserve test like FSH, all hormone analysis along with AMH.
Right, you are right. Does anybody want to do MRI, laparoscopy, anything further?
I think the best transvaginal ultrasound is enough, and we can see the other endometrium. You will see any ovarian, mild ovarian endometriomas, or you will see for the mobility of the uterus.
Yeah, definitely, because today ultrasound is extension of the eye at the examining finger, and accuracy of ultrasound is very good. It's very good for seeing the chocolate cyst adhesions, adenomyosis. Rectovaginal endometriosis can also be studied, and you can apply the IDEA group of consensus. You can see the nodules like this, posterior compartment, anterior compartment. We would say that it's as good as MRI, but of course MRI has a little more accuracy. So ultrasound will give you fairly accurate diagnosis in about 85%. Sensitivity and specificity are almost about 85%. Any biomarkers? Will it help?
MicroRNA can CA120.
Yeah, it's coming in, but I think we require more concrete levels. Today we do not have exact, it is being researched, And CA125 is not of any use anymore. Salivary tests are not available to us, though they say it is 90% accurate. So biomarkers are of not much use to us just now. And anybody wants to give therapeutic test, medical management?
For infertility patient, we don't advise medical management as it's a relation.
Yeah, definitely
So
no.
we
No
have to
medical
straight away
management
going
for
for
patients with infertility. No point in giving them medication and suppressing their ovulation. You are
ovulation.
losing the important time. Anybody for laparoscopy now?
No, not at this stage.
Not
We would still, if it's in a more pronounced disease, we could take it, not at this situation.
Definitely, yes. Today, once again, laparoscopy, which used to be called the gold standard, I think we can see most of it with the help of ultrasound. And according to ESHRE 2022, only in patients with negative imaging results or where empirical treatment was unsuccessful or inappropriate, you go in for laparoscopy. No role for diagnostic laparoscopy. If at all you do, it is only a therapeutic laparoscopy. So there is no more diagnostic laparoscopy. Only time where you can miss it is the superficial peritoneal endometriosis, which is less than 5 millimeter. Recently, we had a patient like this. She had mild dysmenorrhea. She was given induction of ovulation, IUI couple of cycles, tubes were patent. Then finally, I think one side tube, they had some minimal block. We said, okay, let's put in a scope and see, because she was already married for 5 years. And then we saw she had quite a bit of disease in the pouch of Douglas. She had peritoneal endometriosis. She had adhesions in the pouch of Douglas, which were released. So maybe it will help her to conceive, though she had very minimal symptoms. So high incidence of endometriosis is seen in unexplained infertility also. So sometimes you may be able to give some benefit to the patient by doing a laparoscopy. And according to Chaperon also, there is no place for diagnostic laparoscopy when endometriosis is clinically suspected. It's only therapeutic laparoscopy. And these are some of the latest papers. This is in 2024. Impact of laparoscopic surgery on fertility outcomes in patients with minimal and mild endometriosis. So they have given all the data, the meta-analysis, 97, 99, 2012. We always said there was some benefit, like 30%. In 30% after diagnostic laparoscopy versus 17% without laparoscopy. This is 97, 99 and 2012. Whereas a Cochrane review, 2020 meta-analysis says that clinical pregnancy after laparoscopy was 1.89. That means it's higher chance. Jin et al. Says that increased live birth and pregnancy rate. And Hodgson et al. 2020 meta-analysis says that the pregnancy rate is around 1.63. So laparoscopic surgery may enhance spontaneous conception in patients with minimal or mild endometriosis. Routine laparoscopy is not recommended in asymptomatic infertile women planning for fertility. Expectant management and controlled ovarian stimulation and IUI are reasonable alternatives for these patients. Like Shanmugam said, we will definitely do induction of ovulation, IUI if needed, never jump on them. At the end of it, she is a young patient, 24 years or 28 years and married 4 or 5 years. Maybe there is a role for laparoscopy. Like my patient, we saw grade 3 endometriosis in her and we had to do the endometriosis. So you have to individualize the treatment considering patient's age, symptoms, ovarian reserve and surgical risk. So there is some change in theory now in 2020. So in summary, TVS is an excellent tool for identifying endometriomas, adenomyosis and adherent ovaries. No role for medical management in these patients. Perform operative laparoscopy, including adhesiolysis, restoration of tubo-ovarian relationship, instead of only diagnostic laparoscopy. So the aim is to do a therapeutic laparoscopy and not a diagnostic laparoscopy. Case 2 is Mrs. X, 29 years, is a dentist, married 2 years, trying to conceive for last 6 months, mild dysmenorrhea for 4 months, routine checkup, ultrasound, uterus is normal, right shock is 2.7 centimeter, left ovary normal, antral follicle count 8 in the right ovary, and in the left ovary there was, sorry, the right ovary had a chocolate cyst. Left ovary, the antral follicle count was 8 with the 1.4 centimeter follicle. Male factor is normal. And how will you manage, Dr. Radhika?
Again, we should take a detailed history about the sexual history as well. And
I think it's very important because today's busy days, whether they meet at the right time at all.
Exactly.
No, maybe when the bus comes, the passenger is not there. So
yes. And dyspareunia and those history also we need to take. And then go for a clinical examination. And obviously in the ultrasound, we have seen that she's got a chocolate cyst. And draining this is usually the laparoscopic drainage gives better results. So it's best to do a laparoscopy and drain the cyst. And all simultaneous.
You are Dr. Tamil Selvi, right?
I'm Radhika Gauri, ma'am.
Yes. Oh, Radhika. Okay. Because here the name is written as Tamil Selvi, I thought. And what is your opinion, Dr. Tamil Selvi?
Ma'am, she has been trying only for the past 4 months. Yes, she has a chocolate cyst, but it is less than 3 centimeters. I think actually we can provide 3 cycles of ovulation induction with IUI, ma'am. And then if she's not conceiving, we can plan for operative laparoscopy. That is my opinion, ma'am.
I think, what is Dr. Rekha saying? Rekha Rajesh?
Ma'am, right now even I wouldn't want to do a lap, madam, so early for her. I'd want to give her some time, try maybe with ovulation and IUI also could be a better option, but not laparoscopy right now.
Right, both of you are very much right because you are having good ultrasound in your hand and you have done evaluation of uterus and adnexy. You can elicit the soft markers. You can look at the adhesion, sliding sign, site-specific tenderness. With all of you know that with all this you can make out. This particular lady had a mobile ovary, you know. So perhaps she is in the early stage. And this is how it was. We could elicit she also had a follicle in the other ovary. So this is this is, for example, another patient with a larger chocolate cyst and sliding sign here is negative. The whole ovary is moving. It is stuck to it is not sliding over. So you can almost make out whether it is an early endometriosis or a severe disease. And she has got very minimal symptoms. Male factor is normal. And there are also papers which have said that unilateral endometrioma in 6 observation cycles, in 6 months, in 189 ovulatory cycles, they saw that there was 43% pregnancy rate when it was a unilateral endometrioma. So early disease, unilateral endometrioma, ovulation continues beautifully, and 43% of the patients conceived during the observation cycle, observation period. So definitely, I think both of you are right. We will not go in for a laparoscopy first. We'll give her a chance to. This particular woman, because there was a 1.4 centimeter follicle on the other side, we told her come back after 2 days and we saw 1.8 centimeter. We told her to try the fertile period because many of the couples today have no time to meet at the right time. Right. So they keep missing the bus. So this lady, young lady, she conceived in the very first cycle that she came to us, conceived naturally, and she went off very well, and she even had a vaginal birth. So young patients, minimal endometriosis, be patient. If she had not conceived, perhaps we would have asked her next cycle to come for tubal study and then IUI, the way you said. You are very much right. Happy that all of us are thinking alike. Thank you. This is case 3. Mrs. M, 26 years, married for 18 months. She came seeking fertility treatment, but she says she has severe dysmenorrhea, dyspareunia, dyschezia during menstruation, and she's quite scared of having sex. Elsewhere she has taken Dynogest on and off. Male factor normal, and ultrasound elsewhere showed chocolate cyst 6 centimeter in left ovary, 3 centimeter in right ovary. So how will you manage? Young lady, 26 years.
I would like to do ovarian reserve test. I would like to do AMH and also.
Right, her AMH is 2.9.
It's okay. Then I would like to order for MRI also to assess the severity of the disease, whether there is associated DAE also.
Right. Yeah. So because of dyschezia, you would like to have a little more idea about that. If you're an excellent sonologist, like yesterday I was talking to Dr. Bhupati. He said most of it we can make out very nicely with transvaginal ultrasound. But if the patient can afford, definitely MRI is very good, just that it costs a little more. So after this, what would you like to do? Surgery, ART, sclerotherapy?
In this patient, we would do a
Like
laparoscopy,
stage
madam.
4, you can advise her straight away IVF.
Dr. Shanmugavadivu?
I go for IVF, ma'am, directly.
Dr. Rekha?
We would do a lap with probably drainage because they said 6 centimeters. I thought we would do a lap, madam, and then plan for probably IVF.
Yeah, you're right. Let us look at her plus point. She's young, her AMH is good, male factor is normal. So her AMH is 2.4 and she's only 28 years. She probably never had sex because she was so scared of having it. So I think for a young lady with a good AMH and normal factor, laparoscopy is the ideal because she has got pain. She definitely needs laparoscopy. If she did not have pain, perhaps she'll go in for IVF straight. She's never had sex. She said, I do not know the spelling of sex. So, and we repeated the scan in our center. One was only a regressing corpus luteum, one side, then the other side was 6 centimeter chocolate cyst. So there is no blanket approach for all cases of endometrioma. But whenever there is pain, definitely consider surgery. But before this, you have to counsel the patient thoroughly. How will you counsel the patient, Dr. Radhika?
We should tell them that endometriosis, we cannot as per with this, it might be severe or it might be moderate. So we should tell them it depends. And the risks of surgery as well because of adhesions, there can be injuries during the procedure. And also, and it is a little bit difficult to conceive with endometriosis disease as well. Disease per se can cause difficulties in difficulty to conceive. So we should explain to them the success rate and I think they might need to go for IVF in the future. But we can also tell that draining might help. So we should have some time limit for her conception. After that, she can try for natural conception after some time after the surgery.
Yeah, thank you. So you will tell her that her fertility may improve, though there is no guarantee. Number two, perhaps there can be some ovarian tissue loss when you remove the chocolate cyst. The surrounding healthy follicles may go away, so your ovarian reserve may come down. You will also tell her about the chance of recurrence. In spite of best surgery, there can be recurrence. So always take a proper consent because they think that it's a cure. 100% cure agumilia. Everybody wants it to be God. 100%. So I tell them there is no 100% in life anymore. So you tell them about the risk factors of recurrence also, apart from the operative risk.
And they do come back with the cyst and then they think we haven't done it. Sometimes it happens after 3 months, they come back with another cyst, endometriotic cyst.
And also what happens is sometimes the doctors may do a partial excision and may leave the base of the cyst because some of them are scared to go to the hilum. So we do a partial excision and when you give a lupride and when you see them after lupride for 3 months and see them after 6 months, so the cyst is back because it was only a partial excision. So whenever you do an excision, do a complete excision.
Okay.
Have you heard of the sandwich technique or the other method where you do a excision and ablation together? You do most of it, you do excise, but as you reach the hilum, you just do the ablation around the hilum. Do not apply cautery there as much as possible. So it's a combination of excision and ablation. And there was one sandwich technique by Donay et al. That is, you go in and do a laparoscopy, drain the cyst only, give a good lavage, followed by GnRH therapy for 3 months, where the cyst wall will become smaller now. So instead of pulling out a cyst from a large cyst, now the cyst is much smaller And then I think the damage is also less. So a second laparoscopy after the JNRH. But this is very difficult to explain to the patients to come back for a second laparoscopy. But sometimes you may need, if you see a young girl with two large chocolates, 10 and 12 centimeter. We saw once in a young girl of 17 years. This is about 20 years back. And what we did was, we did a good lavage of the cyst and we did eversion of the cyst wall like you do in hydrocele. And we gave her danazol those days. We gave her danazol, and after 5 months when we saw, the ovaries were beautiful PCO ovaries. And very much that same year, she was turning 18 and her parents got her married and she conceived within 6 months and it was all happy ending. So we did not do excision. We did just gave a lavage and we told her that later she may require a laparoscopy, which she did not. So this is the sandwich technique, but rather difficult sometimes to explain it to the patients. So whenever you do a surgery, do a good excision and do not leave any tissue because the chance of recurrence are very high. And look at the, see the tube is very supple. Both tubes are supple and tubes were patent, though there were additions to the uterosacral. So it is automatically grade 3. So what will you tell her post-operatively? I think all of us will
Conceive at the earliest time.
Conceive at the earliest. Very good. And she will say, what are my chances of conception? What will you tell Dr. Shanmugavadivu? How will you assess the chances of conception?
We should also calculate the EFI, ma'am, endometriosis fertility index.
Right. You can see it here. You look at the history. If the age is young, the scoring is 2. Age is more, 36 to 39, scoring is less. If more than 40, the scoring is 0. And years of infertility also get a scoring. And whatever is the tubal function at the end of the surgery. So least tubal function, all this is added. And
the EFI is
scoring,
7
you can
to
ask them to
10.
go in for IVF straight because the chance of conception is less. Scoring is good, like above 7. They have a higher chance of natural conception. But how long will you ask her to wait for natural conception? Or will you go in for any active management? This our patient.
If the EFI is good, we can wait.
Pardon me?
If the EFI is good more than 7 to 10, then we can ask her to wait for a few months, 3 to 6 months for natural conception. If she doesn't conceive, then we can ask her to go ahead with
Yes, that is one way of thinking at it. But on the other side, this lady who is grade 3.
Ovulation induction with IUI.
Yeah, I tell all my patients 2 natural cycles because I
With
want them to get
ovulation.
over their fear. 2 cycles you wait after surgery, but try and have a time coitus. And if they did not conceive after 2 months, I call them for IUI. So this lady, we told the same. And very first cycle, she did not try. And second cycle, because she was very much scared of her dyspareunia. Second cycle, she tried and she conceived. And in fact, she went to Trichy and had a normal delivery there. And now the child is 4 years and she's pregnant again. Spontaneous conception. She had come asking, am I all right? And we had seen again a small 2 centimeter chocolate cyst. But within 2 months, she had a natural conception. So when the patient is young, I think perhaps she never had sex earlier because of dyspareunia. So once her dyspareunia was relieved, I think she is pretty good and she has done well. But AFI may help you to make decisions. But instead of waiting for many cycles, it is wiser to do IUI for IUI. How many cycles will you do, Dr.
3 cycles. 3 cycles.
3 cycles. Yes, I agree with that. I do not like to do 6 cycles because the more chance of recurrence seem to be definitely higher with IUI. And IUI stimulated or
Stimulated with them.
It is stimulated.
Stimulated cycle seems to be slightly better pregnancy rates.
Pregnancy rates.
Yeah. So our patient conceived in the second cycle and uneventful birth. Okay. So surgery for endometrioma prior to ART. All of us are very fond of discussing this. Yes or no? So this particular patient, Mrs. K, 36 years and married since 3 years.
Madam, your slides are not visible, madam.
I'm moving
Seen,
the slides.
ma'am.
You're not seeing it?
Seen, ma'am. Seen, ma'am.
See,
Seen, ma'am.
We can see.
Yes, ma'am.
Okay, fine. So Mrs. K, 36 years, married since 3 years. And her BMI is 19. She came for a pre-conceptual counseling. At 36 years, she says, We are cool. We are not worried about infertility. We have just come for a checkup. Regular cycles and severe dysmenorrhea since childhood. She says, so what? I always had the pain. I'm quite okay. And for last 1 or 2 months, she has been having dyschezia. Normal male factor. And hemoglobin A1C 5.3. So how will you proceed in this lady? She wants to know what are my chances of getting pregnant.
So we do a transvaginal ultrasound, ma'am.
Yeah, and this is the ultrasound. Uterus, mild posterior wall adenomyosis, right ovary chocolate cyst of 2.6 into 2.5, left adnexal mass 5.6 into 5.2 with the hematosalpinx of 6 centimeter. And left ovary chocolate cyst of 1.6 into 1.2, 2.1 into 1.1, multiple small chocolate cysts in left ovary. Negative ovarian sliding sign bilaterally, bilateral adherent ovaries. Negative uterine sliding sign, POD obliteration. I think Dr. Padmashri has done a very good workup. Pelvic adhesions plus. Her antral follicle count is 7 plus 3. AMH is 1.9. Male factor is normal. So, Pungude doctor, how will you go ahead?
I would like to do a laparoscopy for her to assess the status of the tubes, ovaries, whether they are very much already it has been diagnosed as they were adherent.
So with this idea group of consensus that we applied, what do you think could be the stage of the disease?
It is stage 4.
Yeah.
So we could advise her to straight away go ahead with the IVF, or we could offer a...
You are doing laparoscopy or going for IVF?
First, I will do a laparoscopy first.
Dr. Tamil Selvi, what's your opinion?
Ma'am, she is a case of severe endometriosis, ma'am. So I'll first counsel her for IVF, followed by maybe a laparoscopy to drain the hematosalpinx alone at least possible, because her AMH is already 1.9. If you are going to do laparoscopy and drain this, is her ovarian reserve might come down.
Ma'am, I too would prefer to do a OPU and then plan a laparoscopy before embryo transfer.
Right. Yeah, that's where I stand. I stand with you firmly. So because of bilateral multiple small chocolate cysts, they're small, you know, one large cyst is easier to remove than multiple chocolate cysts. No, you make so many fenestrations and surgery on multiple places on the ovary. Already the AMH is about 1.9 and there are additions. So not going to get, and already there is hematosalpinx. So she will require at a certain stage. Surgery is required definitely, but at what stage? Before ART or after ART? We decided we do ART first and then go in for laparoscopy. Because after laparoscopy, we have to give her time to recover, and damage to the ovaries is already done after surgery. So we said, let us preserve her ovaries, not damage it any further. So we went in for ART. And yes, all this yeah, I think it's a repetition. Does anybody want to give her any medical treatment prior to ART?
No, ma'am.
Ultra long protocol. What are the protocols for this lady? Now all of us agree no laparoscopy first, ART first. So what is the protocol?
Yeah,
can do either
analog
analog
protocol.
or long protocol.
Analog protocol is good for this patient.
Nobody wants ultra long, 3 month suppression. Yeah, all of us agree that
Before,
those days it was a
before
golden
transfer,
protocol.
we can do for ultra.
No, about 5 years back, it was a golden protocol, but later we realized that it simply makes the ovary sleep. You know, then later your requirement for gonadotropins is high and number of eggs retrieved is low. Sometimes even cancellation of cycle was seen. So ultra long protocol is now out of favor.
Also, the quality of oocytes get affected, madam, when you give an ultra long protocol.
Pardon me?
The quality of oocytes get affected again with pre-treatment for long.
No, we are worried more about the number of oocytes, whereas even when one follicle and one oocyte was retrieved, I saw that the quality was pretty good and people conceived with a single oocyte and single embryo. but the number of oocytes retrieved was much less. One lady, we cancelled the cycle that month. We asked her to come after 2 months. And then we stimulated her because somebody else in the neighborhood had given her some 6 cycles of Lupride. So we waited for 2 months for her to get out of that suppression, and then we stimulated her. We had 2 oocytes, 1 embryo, she conceived. We gave her a choice. Do you want to drop this cycle and try later? She said, no, whatever has come is very precious to me. Go ahead. So quality of oocytes was good, but number of oocytes were much less. So today we are giving either agonist or antagonist. Both seem to be equally effective. There is nothing better than the other one. But occasionally the long protocol of agonist seems to be better because you can synchronize the cycle and number of follicles, number of oocytes sometimes will be slightly higher in the agonist protocol than the antagonist. It's a luteal protocol. So this lady we put on luteal protocol, started around the 21st day, and we did a egg collection. And we got about, I think, 5 oocytes. Long GnRH protocol, 5 oocytes retrieved, 4 embryos, 2 morula and 2 into 16 cell. All were vitrified. So what do you do next?
Then we go for the
Collection is over.
surgery.
What do you do next?
Then we go
Post-operative.
for the surgery.
Anybody wants to just give her a suppression and then?
Yes, ma'am.
Meanwhile, 1 week after recollection, she came with pain. Pain was more. So now we sent her for MRI. And now it showed a mild hydroureter and hydronephrosis, which was not there earlier. Because after the enlargement of the ovary, there was a slight compression, extrinsic compression of lower ureter by left ovarian lesion. So we gave her antibiotics, waited for another 2 weeks. It was only mild. So we took her up for laparoscopy, I think 3 weeks after the egg collection. Because there's no point in giving her medication and wait. Anyway, she requires drainage of the chocolate cyst and excision of the hematosalpinx was done. You can see it is completely plastered. Bowels are all plastered. Uterus is buried among the adhesions. Then we did a preventive stenting right in the beginning, and the ureterolysis was done. Stent was retained for 6 weeks, and this is the end of the surgery. You can see so many adhesions had to be released. So had you done it before ART, I'm sure your egg collection would have been worse. So now we had 4 good embryos. So what will you do after the surgery? Her recovery from surgery was good. How long will you wait after the surgery?
You can put her on Lupride depot for 3 months.
Very good. Yeah, because she already had posterior wall adenomyosis. So you have to give her a suppression. So she had a stent for 6 weeks and she had a suppression for 3 months. She had 11.2 Lupride depot. And does anybody prefer Dynogest compared to Lupride?
Lupride is better, ma'am, than Dynogest.
Yeah, in our clinic, always, I think we are very fond of GnRH agonists because many papers have said that the volume reduction is much better, much faster with GnRH analog. After 2 to 6 months of suppression, the mean uterine volume significantly reduced from 180 cc to 86 cc. The papers by Zhu et al. And New et al. Also has said that after pre-IVF suppression, the implantation rate went up from 16 to 32%, ongoing pregnancy rate from 21 to 48%, and pregnancy rate from 24 to 51% with long-term GnRH treatment before embryo transfer. So that's what was done. And Dynogest has been compared by others. Dynogest is very good for the pain relief, but not so good for the volume reduction of adenomyosis. And this is a paper by Matsushima et al. They studied for 16 weeks. GnRH analog, the uterine volume came down from 307 to 177 cc, and low dose estrogen progesterone, that's OCP, the volume came down from 226 to 230, so no change at all. And Dynogest also 232 to 262 cc, so no change. So over 16 weeks, there was no change with OCP or Dynogis, whereas GnRH worked wonders. So almost, I think 50% reduction. It came down from 307 to 177. 40% reduction happened in 16 weeks, which was very impressive. So I think we have been using from 2005 GnRH analogs, and we are very fond of that. Now, of course, we are trying a little bit of GnRH antagonist. We have seen good reduction in volume when we use 200 milligram twice daily. 200 milligram once daily is not working. We have seen ovulation happening with 200 milligram once daily, but 200 milligram twice daily is giving us results. So maybe slowly it may replace the injections. So this particular lady, we transferred a single blastocyst, conceived singleton, and LSCS at 37 weeks, and she did very well. Now I think we'll have just short answers. This is Mrs. X, 31, married 3 years. Husband has severe oligoasthenoteratospermia. She has a chocolate cyst of 4 centimeter and AMH is 2.9. So what will you do for her? You will do surgery, ART?
Husband also has a
He has
oligoasthenospermia.
and she
Go
has a
for
4.
ART.
Madam, what is the size of the endometrium, madam?
4 centimeters.
Is it unilateral, ma'am?
Yes, it is unilateral.
Then we can actually do laparoscopy, drain the cyst, and then continue with the ART.
Now, once again, because today, if you look at X-ray, they have removed this unless there is a difficulty in egg collection or she has severe pain. Try to avoid laparoscopy because once again, you are losing some healthy ovarian tissue. Again, the argument is that the other ovary is healthy. So going for ART, you will get good eggs because she also has an AMH of 2.9. So avoid surgery unless you have difficulty in egg collection or severe pain or fear of rupture. So prior to ART, once again, this lady, definitely we are going in for ART, but explain to the patient for some reason if there is no pregnancy, later we may consider a laparoscopy. Otherwise, you can do an egg collection, suppress the disease, maybe 11.25 for 3 months suppression and then transfer the embryo. People have done very well without surgery. If she doesn't do well, perhaps the next time you can do a surgery and then go ahead with ART. So this lady, we are voting for ART first and avoid surgery. Because earlier we used to think that there is toxicity and the oocyte quality is not good. But today lots of papers have come which have shown that the oocyte quality is pretty good in endometriosis and there is no need to clean the ovary. So we are trying to avoid surgery as much as possible. So Ashri again says that clinicians are not recommended to routinely perform surgery for ovarian endometrioma prior to ART to improve the live birth rate, as current evidence shows no benefit and surgery is likely to have a negative impact on ovarian reserve. So consider to improve endometriosis-associated pain or accessibility of the follicles. So the decision to do surgery prior to ART should be guided mainly by pain symptoms and patient preference, as its effectiveness on reproductive outcome is uncertain due to lack of randomized studies. So this is the ESHRE stand in 2022. Because endometriosis, presence of endometrioma reduces the AMH, and if you do surgery, there is a surgical insult further, which can further bring down the ovarian reserve. So let us try to go in for ART straight. So this is a fertile battle. On one side, we say do surgery. On the other side, we say do not do surgery. If we do surgery, we have the cost. Surgeon skill is important. Possible surgical complications. Ovarian reserve can come down. Incomplete surgery recurrence may delay ART. If you do not do surgery, progression of disease, difficult oocyte retrieval, risk of cycle cancellation, follicular fluid contamination, infection, pelvic abscess has happened, mind you. This is something all of us have to think of. If you tap it during egg collection, sometimes pelvic abscess can happen. So please explain all this to the patient. Never become a god, saying that, no, I'm going to help you. These are all the possibilities and take consent, written consent and explain it to them. Some risk of rupture of the cyst with subsequent chemical peritonitis if you go ahead with the intact cyst of big size. So informed consent is very important. Resection of a suspected endometrioma prior to ART is needed in the following circumstances. Rapid growth, suspicion of malignancy noted on ultrasound, painful symptoms attributed to the mass, potential for rupture in pregnancy, inability to access the follicles in normal ovarian tissue. So, yes. And what precautions will you take if you do an egg collection with the cyst on? Dr. Rekha.
Puncture the or aspirate the endometriotic cyst and be very careful about it. Yeah.
Yeah, you can just give, if you happen to puncture, then you just give a wash and you can still use those eggs. Nothing will happen. But we always try to avoid doing a tapping because chemical, you can get into infection sometimes. And yeah, so this lady, yes, okay. This is next case, case 6, 34-year-old female. She is anesthetist, husband is orthopedician, both very busy people. Sperm count 25 million, 15% motility. She says mild dysmenorrhea. She's not really worried. She's only for last 3 weeks, she had a left-sided abdominal pain. She says mild dysmenorrhea, occasional dyspareunia. She doesn't complain much about pain, but for 1 week, I think she has had a left-sided dragging pain. And her normal uterus, no adenomyosis. AFC is 10+10. And ultrasound showed a left adnexal mass, 5 into 2.7. Tubular cystic echo 3.8 into 1.4 centimeter with internal septation. You think that she has very mild symptoms, and this is what we saw. What is it?
Hydrosulfates.
It's a hydrosulfates. So how will you go ahead, Dr. Shanmugavadivu?
Since she's having pain, I will go for first laparoscopy, ma'am.
Right. Yeah, you will go in for laparoscopy. She also has a very good AMH, 4.9. So one more point for you that you can go in for laparoscopy. And does anybody think of IUI here?
No, ma'am, we'll do laparoscopy, remove the tube, and then evaluate the other side of the tube, and then allow her.
Definitely. So we went in for a laparoscopy, and you can see, I told you that the extent of disease and symptoms have no correlation at all. She said only 1 week she has been having dragging pain, and you can see everything is like a frozen pelvis. Left side, we couldn't see anything because it was all the bowel. So Damodar had to release everything. Lot of ediciolysis happened, and we could do it boldly because her AMH was, I think, 4.9. Very good AMH. If it were 1.2 or something, I would still go ahead with the egg collection first, in spite of pain. We'll give her something for pain, do the egg collection, and then suppress her. But this lady, we went in for surgery because of good AMH. And what protocol for her?
Antagonist.
Antagonist, agreed, yeah. 6 oocytes retrieved, 5 embryos, and she had 2 embryos transferred, twin gestation, LSA is at 37 weeks. She was a very happy mother. She said, 1 August I came into Rao Hospital. By next August, I believe she had the twins on her lap. So she was very happy. Fresh or frozen embryo transfer?
Frozen embryo transfer, madam.
Yeah, definitely, because the success rate is definitely much better with frozen embryo transfer. Though again, the pendulum is swinging back. There are some papers from UK coming up saying that they want to do fresh transfer, but in my experience, frozen embryo transfer has been the best. So thank you all for agreeing with me. Recurrent endometrioma. Mrs. P, 25 years, married since 2.5 years. Primary infertility. Severe dysmenorrhea on day 1. She has undergone, February 23, she has undergone histolaparoscopy with endometriotic cystectomy elsewhere in the medical college in Coimbatore. Right ovary, 2 chocolate cysts. And after laparoscopy in February, she was given 3 Leupride, 3 injections. And in 3 to 4 months, it was quiet because she had no menstruation, no pain. But in 6 months' time, all her pain was back. So when she came to us, this is the ultrasound we did. And again, she had right chocolate cyst of 3.5 into 2.3. Left ovary enlarged to 6 into 8 centimeter with multiple chocolate cysts. And we could hardly see her follicles, AFC 3+3. Multiple peri-ovarian adhesions as per ultrasound, loculated fluid spaces. So perhaps it was an incomplete surgery, we do not know. You try negative sliding sign, POT obliteration. So how will you manage her?
In spite of ineffective surgery, the AMH is 6, madam.
Pardon me?
The
She
first
is young,
surgery
she's
was
25 years. Male factor is normal and recurrent chocolate cyst. Recurrent or persistent, whichever is. But she has come to your doorstep now. She wants a baby and she has pain.
as she's symptomatic. We can go ahead with the laparoscopy first.
What will help you to make a decision? You must be able to tell her boldly, yes, we will help you.
Because
AMH.
AMH is 6. Our
Ovarian reserve
AMH
and
is 6.
AMH. AMH was 6. And you can boldly lift your head and say, yes, I think your ovary may not be damaged because the AMH is so good. And I didn't believe. I sent one more sample to the neighboring lab, micro lab, and they gave the AMH as 8. But you look at the ovary, you could hardly see the follicles. Everything was replaced with chocolate cysts. But we explained to the patient and we went ahead with laparoscopy. And we had to do a proper excision of the cyst wall. And bilateral cyst excision, ediciolysis with a good count. Sigmoid colon also was adherent. The left lateral pelvic wall, bowel adherent to posterior wall of the uterus, released. Bilateral spill plus. But with all this disease, she didn't want to wait for a natural conception. Post-operatively, she had lupride, was given. How long will you wait after surgery to go ahead for? Does anybody want to do IUI now?
Yes, ma'am.
Tubes are patent.
Yes, ma'am. We can try, ma'am.
For at least 2 to 3 months.
Definitely not.
No.
The way she has come up with the grade 4 endometriosis within 6 months of the first surgery, same thing will happen after the second surgery also. So she was, begging for anything to get her embryo safe. She said, before it happens again, please do something for me. So she, in fact, underwent 2 stimulations because in the first cycle, we got only 3 oocytes and 2 embryos. Maybe we had done it a little early, like I think we stimulated her after 8 weeks. And 2 embryos. So she underwent a second stimulation. First was I think antagonist stimulation, and second was agonist stimulation. She had 6 oocytes. Because of the AMH 6, AMH was high. So we had gone for antagonist cycle first. Second time went in for agonist cycle. 6 oocytes, 4 embryos. All were vitrified. And then again she had a lupride depot. She had a down-regulated HRT, single blastocyst transfer, positive, singleton pregnancy, low-lying placenta, but it sort of moved later. She had an uneventful pregnancy and a term childbirth. She did very well. So I think her AMH gave us the boldness to tell her that, yes, AMH is 6. We'll definitely go ahead with the excision. Otherwise, we're wondering whether you should just do a drainage. If you had done a drainage within 3 months, I think she would form chocolate cysts again. So AMH, ovarian reserve, helps you to decide, plus young age. So case 8, Mrs. C, 26 years old, severe dysmenorrhea, dyspareunia, diagnosed with DIE and bowel endometriosis 3 years back, and now she gets married. No endometriomas. AMH is 2.5. She's on medical management so far. Keen on conception. So what will you do for her? Do you want to go for surgery, IVF? She is 26 years old.
The AMH is low. We'll go for
2.5, yeah.
AMH is 1.2, madam.
1.2.
1.2. Oh, okay. Now I'm getting this doctor's photographs here. I'm not able to see actually. Yeah. Does anybody want to do surgery?
When there's
Surgery for DIE?
no, ma'am.
Yeah. So it's a lot of controversy now. For a long time, we said there is no role for surgery. And once again, these patients with DIE will have perhaps associated adenomyosis, tubal block, pelvic adhesions, etc. Surgery or no surgery? That is the controversy now. For a long time, we said no surgery for DIE. Perhaps you can do a tubal study, and if tubes are patent, you can still give her a chance to get pregnant by a couple of IUI because she doesn't have any obvious endometrioma. And she has done well with the medical management so far. So stop the medical management and you can take her up for IUI or IVF, depending on the tubal status. She's 26 years. So maybe 1 or 2 cycles of IUI is not going to hurt. She may not agree for IVF directly because she's married only for some 6 months or 10 months. So you can do IUI. If it doesn't succeed, then you can always discuss with her IVF, but there is no need to rush for surgery directly. But of late, some papers are coming up which say that by doing surgery for DIE, they even had natural conception, especially if the IVF fails. The dictum now is that you can do surgery, release the additions in the pouch of Douglas, and sometimes they may have spontaneous conception, or even the repeat IVF gave better results. So now it's a controversy in DIE to do a surgery or not to do a surgery. It all depends on your surgical skill. We're all ART specialists, we'll not think of surgery, but they endoscopic surgeons, skillful, they will think of surgery. So if there is a failed IUI, failed IVF, especially, perhaps there is a role for surgery because the lady is young, 26 years. 26 years, low AMH also can give you good results. So for a long time, we said IVF endometriosis gives less success, but there have been later meta-analysis and studies by Harv et al., which showed that ovulatory dysfunction, male factor, endometriosis, the success rates are almost standing in one line. The success rate of endometriosis IVF has definitely improved over the last 5 years. And this is case 9. Mrs. S, 20 years with dysmenorrhea. Dysmenorrhea 2 years, married 2 months with dyspareunia. She has come to us for dyspareunia and she's married for 2 months only. On ultrasound, she has bilateral endometriomas, 2 centimeter and 1.7 centimeter on the other side. So how will you manage?
She's having dyspareunia.
And we were so much worried about her. And then she says, no, I've not come to you for fertility. I've come for symptom relief. I want to wait for 2 years. I'm only 20 years. It was a love marriage. There's a lot of problem between the families. Then finally they got married. Maybe in that anxiety over 2 years, I think her endometriosis should have become worse. She says, I want to relax for 2 years.
Progesterone,
We can do an
We'll
MRI.
do the AMH. We'll do a AMH, ma'am, and also MRI we can do, ma'am.
Yeah, MRI you can always do to clinch your diagnosis. And if you're a good diagnostician, good ultrasound, maybe there is no need for MRI.
and also
AMH.
guidelines, we cannot start her fertility treatment because she's only 20
Like
years.
everybody
22.
else, like see, we're all traditional gynecologists. The first thing I told her was have babies. Go in for pregnancy. You're 20 years, you married the man you loved. So what prevents you from having a baby? She says, no doctor, I want 2 years. I want to relax. She said, fighting with the families, this side and that side, they said they were going really very much frustrated and finally they are married. They want 2 years.
We can
Do you
start her
want
on
surgery or do you want to do medical management?
Can give
What
her
about Depo-Provera, ma'am? The role of Depo-Provera here?
Yeah, Depo-Provera can also be given. So all of you are thinking of medical management, isn't it? Anybody wants to diagnostic laparoscopy to see what stage she is?
No,
Not at this stage, ma'am.
Yeah, once again, Eshere in 2013 said that laparoscopy is the gold standard for diagnosis. Clinicians can perform a laparoscopy to diagnose endometriosis, but in 2022, Eshere says patients with negative imaging results or where empirical treatment was unsuccessful or inappropriate, GDG recommends considering laparoscopy for diagnosis and treatment of suspected endometriosis. So it's more of therapeutic laparoscopy than diagnostic. So all of you are right in saying that you want to go in for medical management and not for laparoscopy because you do not want to go and operate on this young girl. So treat her like a teenage endometriosis, adolescent endometriosis, give her medical management. What do you want to give? COC, Dynogest? You have a good choice or GnRH antagonist,
Dynogest, ma'am.
Upride. Anybody wants to give OCP? OCP Provera can be given. This lady had a lot of pain, she said, in the last 2 months after marriage. So we gave her a shot of Lupride 11.2 and she came after 3 months. And now we have put her on Dynogest. Of course, in case you say Egolix for you can give 200 BD for about 3 months and then bring down the dosage to 1 daily. But whenever you give egolics or the antagonists for more than 3 months, you have to give an add-back regime with progesterone. That's very important. So this lady is on now Dinoges and she's feeling much better. So a young girl like this, there is no need to do a diagnostic laparoscopy or a therapeutic laparoscopy. Medical management, if there is no response to medical management, that's the only time you may go in for surgical management. So how long can you give Dynogest? Any side effects with Dynogest?
Breakthrough bleeding maybe there.
Yeah. And any reduction in BMD, bone mineral density? According to Visado's study, this was done in adolescents, 12 to 18 years, over 21 centers of Europe. They saw that it was very safe to give it up to 52 weeks. And this was in 2014. But of late, we have had studies by Dr. Reamer and also the Visan study, which has seen that it is almost safe to give it up to 7 years. And anybody wants to give Dynogest with estrogen? I'm not very much for this because again the studies say that when you give it with estrogen, the volume reduction was not the best. There is symptomatic relief, but volume reduction was not very good with the endometrioma. So I'm more for giving progesterone alone, Dynogest alone, rather than a combination of Dynogest and estradiol. I think this is our last case. Mrs. S, 34 years, infertility of 5 years, severe dyspnea. Is it okay? 5 more minutes?
Yes, ma'am. Sure.
Last case. Periods 3/30 regular. Laparoscopy for grade 4 endometriosis 3 years back. Failed IVF 6 months back. Her AMH is 1.3. Male factor is normal. Very keen on pregnancy. And this is her. So can you tell me something about this, Tamil Selvi? This picture?
Ma'am, I'll proceed with IVF, then start her on...
How will you describe this?
This is a mixed echogenic lesion in the maybe POD. I don't know
wall, yeah.
if it looks like... I think the ovary only, ma'am, with
No, it is in the uterus. It is a posterior wall lesion. You can see it also with the 3D here.
Okay, a focal
you can see the
adenomyoma.
endometrium.
Okay.
It almost mimics a myoma.
Okay.
And it's almost impinging on the endometrium. And it is an adenomyoma. Posterior wall adenomyosis, 4.7 centimeter.
Okay.
And she has got bilateral small ovaries. Her AMH also is slightly on the lesser side. And they also have tiny echogenic spots, tiny chocolate cells. So what do you want to do now? Surgery, ART, medical management?
I'll do ART
Earlier,
first.
already laparoscopy done earlier.
We would do ART first.
We can do ART first, then do adenomyoma, we can do adenomyomectomy, or we can go ahead with the GNRH analog.
What will you do, Dr. Rekha Rajesh?
I prefer to do ART first, madam, and then do a adenomyomectomy, give her a suppression break, and then frozen embryo transfer.
And what protocol?
Preferably long protocol, madam, for this patient.
Yeah, you are very much right. We went ahead with the antagonist protocol, and I think she had some 4 or 5 oocytes. I know what we have written later. Forgotten. And we vitrified the embryos. Then we gave her a loop, right? We did not do any surgery. We gave her a suppression of 4 months. Because at the end of 111.2, her suppression was pretty good. This adenomyoma had moved away from the endometrium. So we gave her 1 more month suppression, 16 weeks, and then we did an embryo transfer, and she conceived, and we were happy, and she had a term, whatever, 37 weeks cesarean section. So we did ART, suppression of adenomyosis for 16 weeks, and then we did the transfer, and she has done very well. So, yeah. Singleton, again, she had a low-lying placenta, LSCS at 37 weeks. Yeah, many of them could have. So who will benefit from uterus sparing surgery in adenomyosis? When will you operate, Dr. Pungode? Dr. Pungode, you're not wrong. Maybe we'll slowly start doing hysteroscopic correction in these patients. But I prefer not to do a surgery straight. I would always like to do a medical adenomyomectomy. If it is not happening, then go in for a surgical.
Unless she has repeated failures, we
Then
won't go
focal
into
abnormal
adenomyoma
uterine bleeding
and
or severe dysmenorrhea not responding to medication, recurrent abortion or recurrent implantation failure, not responding to medical suppression. These are the only times that you have to go in for surgery. I have heard endoscopic surgeon stand in a conference and say, oh, this 2 or 3 centimeter adenomyosis doesn't respond to medical management. Anything more than 3 centimeter, you have to take up for surgery. I do not agree with that. We have seen 5 centimeter, 6 centimeter adenomyosis responding beautifully and conceiving. What is your fear when you do an adenomyomectomy?
fear of scar rupture during pregnancy.
Fear of rupture, yes. This is the most important. I've seen somebody in the neighborhood, some other center, there was a rupture, and I think that lady had twins. It happened in 32 weeks. So whoever conceives after adenomyomectomy, kindly ask them to stay around the hospital after 28 weeks. And if they're going away to their hometown, give a proper letter describing what type of surgery was done. Were you happy with the closure of the myometrium or not? All these things have to be told to the doctor, because she may be going away to, now there is a habit, many centers are referring to some center, they undergo IVF there, they go back to the original doctor later. So please give all the details to the obstetrician who looks after her, because no woman should die of rupture uterus during pregnancy, after a very precious pregnancy. So giving all the details and especially asking the lady to stay around. And maybe after 30 weeks, you can even ask her to be in the hospital or near the hospital. So women with adenomyosis associated infertility, routine infertility workup, including measurement of ovarian function and semen analysis. Young ladies, mild adenomyosis, they can get pregnant like anybody else. But if they're not getting pregnant, bigger adenomyosis, long JNRH protocol, followed by natural conception or IVF can be done. Surgery is not taken into consideration before ART. If there is a failure, you try a couple of ART. Sometimes first IVF did not succeed. Maybe there is a hitch in the cervical canal. Maybe there is thick endometrium. Sometimes we even had to put Mirena into these patients. First, embryo transfer did not succeed for a patient. Then I realized her uterine cavity length was almost 10 centimeters. So we gave her another JNRH depot plus intrauterine device, LNG-IUS, waited for 6 months and then did a second transfer. She's a very happy mother. Do not hesitate to wait for 6 months, because even if you do a surgery, you have to wait for 6 months. So it's worth doing a medical adenomyomectomy, wait for 6 months or whatever is the appropriate according to the size of the, there are no proper guidelines. So repeat ART does not give success. Maybe there is a time that you have to consider surgery, not otherwise. So I think we have had a very good discussion today. No more, yeah.
Madam, I have a question, madam.
Yeah.
If there is a diffuse adenomyosis and the uterus size of 16 weeks, if a woman comes like that with infertility, how can you proceed with this type of cases?
According to me, up to 12 weeks, I was very happy with the volume reduction. Even if it is 16 weeks, sometimes you can try giving JNRH plus letrozole plus intrauterine device. Some of them respond very well. And sometimes 12 weeks size uterus, they have conceived and they have gone to term, or even up to 32 weeks. But 16 weeks sometimes can be a challenge. Up to 12 weeks, we have had patients who are 330 cc. The normal uterine volume is about 60 cc, and these patients were 330 cc, like a 14 centimeter uterus. And such patients, 2 patients, responded very well to 6 month suppression. With the embryo transfer, they had pregnancy and no preterm labor. Because many times your fear of obstetric fear is preterm labor, placenta previa, and sometimes maybe even PPH, hysterectomy, all this can happen. So you have to explain to the patients that you can have obstetric catastrophes with adenomyosis. So big uterus, like what you said, Dr. Pungode, you can suppress it to some extent and then later do adenomyoectomy if it is not responding.
It is a diffuse adenomyosis. If it is not a localized adenomyoma, it is diffuse adenomyosis like a globular uterus of
So now
16
you
week
have
size.
all the 3 petal, 4 petal, so many types of petals are being described. So you can always do the surgery. I'm not against surgery. We have also done surgery, and one of my patients conceived twins after surgery. And she did very well, no rupture. In fact, a cesarean, we did not even see any additions or indentation on the scar. She did so well. So surgery becomes the ultimate. I think both are complementary to each other. Even after surgery, you can give another 6 months of separation with GnRH, and maybe they will conceive. So, yeah. I think we have had a very nice evening. Thanks to all my panelists for very active participation. And I think they were all very good in answering. Thank you so much.
Thank you.
Thank you, madam.
Thank you.
And I thank the organizers, Dr. Sampath Kumari.
She could really change all those situations. Dr. Vidya Prabhakar.
Dr. Vidya Prabhakar, yes.
Thank
you so much, Dr.
Thank you so
Vidya.
much, ma'am. It was a very wholesome and you almost managed
Vidya
to
is
touch
very
all
sincere.
aspects
She
of.
sits down through all the programs and encourages all of us. Thank you, Vidya.
Thanks a lot.
Thank you, ma'am. Thank you, ma'am.
She's got a your chat.
Well, thank you, Asha madam, for touching all aspects of endometriosis and infertility and giving us quite a wholesome idea about the whole thing. And touching on all the controversies also, it was a very nice panel. Panelists were all very active. On behalf of the TNFOG, I'd like to propose the vote of thanks for today's webinar. First of all,
Yes,
hello.
ma'am.
Are you able to hear me now?
Yes.
So I'd like to thank our chief guest and guest of honor for joining us, knowing about our program, encouraging us and inspiring us to do more. I also thank the chairpersons, the faculties, the panelists, and the speakers, our judges who've been doing this every month for us, and the UAs for presenting their paper. I also thank the Shield for their platform and other arrangements. Thank you, one and all.
Thank you, Gayatri. Bye.